Okay, you guys can begin. Just let me know when you want me to change the slide.
Okay, so our presentation is on cinnamon. It's by me, Aslyn, and Taylor. You can go ahead and sit there. Okay, so our class activity. So during our presentation, we just want you to write in the chat box, like if this is a new piece of information that you never heard of or didn't know before, or if it was like you knew that information already, like it wasn't new to you. And then you can go ahead and go to the next slide. Okay, so what is the history of cinnamon and its use? So cinnamon can be dated back to the 2800s BC, where Moses actually used it to make people holy. And then the Romans used it for the digestive and respiratory tracts. They would also use it at funerals to like fend off bad odors from the dead bodies. And then Egypt used it to embalm mummies. And then in the 15th century, it actually led to the world exploration because it was very expensive and highly treasured. And then most cinnamon type of cinnamons is used is the cassia cinnamon. And then there's also other types of cinnamon, and I have it pulled up one sec. The bottom part says ground cinnamon or cinnamon sticks. So what is cinnamon and what is it generally used for? So cinnamon is a spice that is obtained from the inner bark of several trees. Cinnamon nowadays is normally just used as like a flavoring agent, like cinnamon rolls or like chai lattes, yummy stuff. Although some people still use it to like help with digestive issues, diabetes, loss of appetite, arthritis, and to help with brain function. It's also known to help play a role in treating bronchitis. And then what is cinnamon's, I think, complementary therapies? Yeah. So cinnamon is full of antioxidants, which can help with anti-inflammatory properties. So this is like why people use it for arthritis. If you use it with turmeric, it can also double the benefits. Cinnamon can also lower blood sugar levels and reduce insulin resistance. It is recommended for people with type 2 diabetes to take 1 teaspoon of cinnamon a day. It also reduces the risk of heart disease. It contains cancer preventative properties. So it includes the cinnamaldehyde. So this helps protect against DNA damage and cell mutations. It also helps fight fungus and bacterial infections. It's good for oral health. And then it also can help with brain function. Cinnamon is loaded with manganese, which is needed for brain health.
Is cinnamon a specialty supplement or herbal product? So cinnamon is an herbal product. Cinnamon is derived from the bark of various species of cinnamon trees. The leaves, flowers, fruits, and roots of cinnamon trees can be used for medicinal purposes as well as an additive for food. There are differences in the chemical composition of cinnamon products produced from different species or parts of cinnamon trees. So basically, there are different types of cinnamon, and some are more potent than others. Next slide. Compare and contrast cinnamon with conventional therapies. Cinnamon has been most commonly used as treatment for bronchitis, GI problems, anorexia, and diabetes. The most promising study has been focused around using cinnamon to help reduce blood sugar in diabetics. However, only 3 studies reported a significant decrease in fasting blood glucose and 1 in a lowered HbA1c. While using cinnamon in some of these studies has shown benefit in lowering blood sugar levels, others have failed to replicate those results. This was mostly due to using different kinds of cinnamon or other flaws in the studies. But because of this, the NCCIH does not advocate for or support the use of cinnamon as an anti-diabetic therapy due to lack of sufficient evidence. So basically, it helps and has some medicinal properties, but it wouldn't be enough to stop taking insulin and just use cinnamon to control diabetes. And other studies were inconclusive of using cinnamon in various forms to be used as symptomatic treatment of mild spasmodic GI complaints like bloating, flatulence, and symptomatic treatment of mild diarrhea. Cinnamon has antibacterial properties and can help constrict smooth muscle in the GI tract to help with these complaints, but not enough studies have confirmed this yet. Next slide. So interactions and adverse effects. Cassia cinnamon contains a chemical called coumarin, which can be harmful to the liver. Some cassia cinnamon products contain high levels of this substance. For this reason, medications that also affect the liver, like acetaminophen, should be monitored closely because it can increase the risk of liver damage. Anticoagulants, specifically dabigatran, should not be used concurrently with ginger and cinnamon. This interaction could lead to fatal bleeding. So I read about a case where an 80-year-old man with a heart condition was on dabigatran, and he presented with a one-day history of blood in his vomit and stool, which began 3 days after he had started taking a boiled mixture of ginger and cinnamon. The patient became hypotensive and was treated as a case of GI bleeding and hemorrhagic shock, but they were unable to control the bleeding, and the patient died within 24 hours. So it's a really sad story, but it definitely opened my eyes as to what could potentially happen, and I think it's important to educate patients about that, especially if they're on medications like anticoagulants or using other herbal products like turmeric, ginseng, garlic, ginger, and ginkgo biloba, as all of them can increase the risk for bleeding. Also, you should monitor closely in diabetics who are using anti-diabetic medications, specifically albiglutide and acarbose, as it can increase the effects of these medications, leading to hypoglycemia. And then other adverse effects, cinnamon may irritate mucous membranes, and excessive doses may cause hypoglycemia. Next slide, please.
Okay, so like where the active substances of cinnamon like come from. So it's like formaldehyde, eugenol, and camphor, and like trace amounts of coumarin. And they're actually all found in a brand or like a type of tree. They're called laurel trees, specifically bay. And so they come from like these leaves and like the bark of these trees and also the root bark. So like oils and everything are made from these, and they grow all over the world. So there's a bunch of different like countries that have their own version of these trees that produce cinnamon. And then the next slide. So does cinnamon have a dose or a strength? Like you don't cut like a cinnamon stick in half, like measure it. But you're not, like there's not specific amounts that you're supposed to take. No recommended dose or anything, but you should be careful because like more than 1 milligram per kilogram can have an effect on like a person's blood coagulation. Like Taylor was saying, it can cause like bleeding and stuff, so you should be aware of that. It does contain like high levels of coumarins, which can be toxic at higher dosages. And then just know that like ground cinnamon is generally given at like 1 to 3 grams a day in studies of diabetes without being reported with adverse reactions. So like you can use it in diabetes, but just be careful with how much you take. Like you don't want to have a bad reaction because you took too much. And then when used in tablet form, like most of the supplement like manufacturers and stuff recommend that you take between 500 milligrams and 6 grams a day, usually with a carb-rich food to avoid the side effects. But again, it's not standardized. So just know that like each individual manufacturer will maybe have like their own suggestions, but play it on the safe side and just take, cinnamon toast, yes. Like maybe measure it in toast, like Mark is saying, if you'd like, but like less is better in this case. You don't want to take too much. And then the next slide. Okay, so like, is it available in different formulations? Yes, you should not snort it. Like basically, like ground cinnamon and stuff, like please don't snort it and don't try to like take a whole spoonful of it and like swallow that dry. But like there's a whole bunch of them. There's oils that you can put in food, different kinds of those oils. You have like the picture shows like there's leaf oil and bark oils. They come in like sticks. They come in like liquid form. You can get them in gel capsules. You can get them in like the hard, like compressed tablets. Like they come in all kinds of forms. But like you should never, like ingest an oil unless it's like specifically for cooking, because it does come in essential oil forms. Like just like it comes in everything. So just be careful like when you take it that you're reading the right way to take it and that you're not being dumb and snorting it. And then the next one, and those are our resources.
Okay, good job, guys. Does anybody have any questions for these guys about cinnamon? Oh, me too, Amy. Have any of you guys gone up to that little straw market up in Pleasant View? They literally have the best cinnamon rolls. For real. Just getting our PowerPoint. So this week, as you can probably guess, with your other classes, we are going to talk about respiratory drugs. And this is one of my favorite units to teach, partly because a lot of these drugs are over the counter, and most, if not all of you, have heard of them. And they're a lot more familiar to most of you. So it's a little funner to talk about because you are more familiar with what I'm talking about. I'm almost done. Loading up this. Okay. Food should be allowed as a class activity. Absolutely. Like, I'm all for that. If you guys, like, if we were in class and you guys had, like, if we were in class and you guys wanted to, like, bring cinnamon rolls for cinnamon, I'm all for that. Absolutely. Amy, that's a good question. You know what? Let me get an answer for you. Just a hot second. Okay, when she lets me know. When she texts back, I'll let you know. For sure. Okay. So we are going to talk about first is upper respiratory disorders. So chapter 35 and chapter 36. Those are the two we're covering. They're honestly not that long. And we're just mostly going over allergies, colds, asthma, and COPD. That's really kind of it. True story. I'm pretty sure you guys can bring like water bottles and stuff like that. I would think that would be okay. As far as like actual open food, well, I'll see. Okay. So you guys ready to tackle upper respiratory? Amy, I'm all for that. Any type of muffins. All right. Okay. I didn't know PNs were eating food, but I don't think it should be a big problem. Like, as long as we don't break out into like a food fight, which, by the way, would be awesome. But we won't do food fights. Okay. Upper respiratory disorder. So we have our upper respiratory and our lower respiratory. There's our learning objectives. You guys can go through that. Oh, let's do fun facts. Fun facts. So, lungs and tennis courts can be the same size. Now you're like, what? How is that? Well, if you take a grown person's lungs and you take the surface area of all the alveoli and you like of anything in there and you like spread it out so nothing's overlapping, it's about the size of a tennis court. You believe that? That's kind of interesting. Also, the air we breathe contains 21% oxygen. Our bodies only use 5% of that. So we're exhaling the rest of that. I can understand the frustration. So when we breathe in our air, the 21% oxygen, we're breathing, what's 21 minus 5? 16. We're breathing 16% back out. So just so something to think about. And then humans exhale up to 17.5 milliliters of water per hour, which is why all of your masks get all damp and nasty. Just saying. You're putting a tablespoon of water in your mask. That sounds kind of gross. But obviously that depends on how hydrated you are, and probably the humidity in the air itself already, and there has a lot of things that it's based off of. So that's a lot of water. Okay, so the respiratory system supplies oxygen for the body and provides protection against inhaled pathogens. What kind of things protect us against inhaled pathogens? Like how does it protect us? Nose hair, this ciliary, is that how you say it? So just the fact that like our sinuses are kind of humid in there, right? It tracks all this stuff. The nose hairs, even just coughing, right? Being able to cough and cough up all that junk. So protects us. Okay. So respiratory system and the process of gas exchange. So we have our upper respiratory system, which is like up here. It's like from our like neck up is our upper, and then this down here, our lungs, is our lower. This should all just be review. Hopefully it's review. Here's our alveoli and our gas exchange right here. All the good stuff. If you are questioning your anatomy here, it's all labeled for you. Okay, so our upper respiratory system, it comprises of the nose, nasal cavity, pharynx, paranasal sinuses, and when we breathe, our body humidifies, it warms, and it cleans the air that we breathe. Pretty good, actually, unless you're living in California or Oregon right now, you might have some problems. It traps and removes particulate matter and pathogens before they reach our lower portions. And how do we do that? How do we trap and remove the particles? Sneeze and we cough. Amy, I probably beat you to it. Sorry. We sneeze and we cough. And the mucus, yes, traps. And then that's when we sneeze, we throw out all of our mucus and yucky stuff. Right? Okay. And then real quick, we're talk about our lower respiratory tract. So lungs, including the trachea, the bronchi, the bronchioles, alveoli, and then even smaller, the alveolar capillary membrane. Okay. So our lungs our respiratory does three things. It ventilates, it perfuses, and diffuses. So ventilation is the process of moving air in and out of the lungs. Ventilation, putting air in, taking air out. Perfusion is blood flow at the capillary beds. So making sure we have the blood flow. Okay. If you have poor perfusion, you have poor blood flow. Okay. And then diffusion, or diffusion, however you want to say it, tomato, is the actual movement of the molecules. So the movement of the oxygen and the carbon dioxide from a higher to a lower concentration. It's the same type of thing when I learned about diffusion, and I don't even know what grade it was. They were talking about like spraying, like they'd spray perfume or something in the air and it would like disperse because it's going from higher to lower concentration. Also, they like with the salt in the water. Anyway, so that's the actual movement of the molecules. Perfusion's the blood flow, and the ventilation is the air in and out of the lungs. Good to keep those straight. So what is the difference between acute rhinitis and allergic rhinitis? These are all very medical technical terms. So who can give me layman's terms what acute rhinitis is and what allergic rhinitis is? Because with a lot of people, if you come in and you're like, yeah, you've got acute rhinitis, they're going to potentially freak out on you. What do you think? Anyone have any ideas? Okay, Jody says you have to clean up after yourselves with the food. Okay. Yeah, runny nose due to a cold versus due to allergies. Right. So acute rhinitis is a cold, and allergic rhinitis are allergies. So sometimes it can be hard to tell if you're having allergies or if you have a cold. So here you go. Here it kind of helps you. I'm sure you guys have seen these kind of everywhere that include COVID-19, right? How do you know if it's the cold or the flu or COVID-19? Well, let's, do these. What do they call these? There's a name for these types of graphs. I can't think of it right now. Anyway, a Venn diagram. Thanks, Leslie. Yes, Venn diagram. So here we have the clear mucus, seasonal symptoms for more than 10 days, itchy ears, nose, and throat, symptoms year-round, rapid sneezing. Over here, fever's a big one. And I never really thought, and they kind of teach you, at least I was kind of taught, that you don't have fevers with colds. That's false. That's absolutely false. You can have fevers with colds. It's a mild fever, though. Like if you get a really high serious fever, it's probably more than just a cold. But you can get a mild fever with a cold. Anyway, sore throat, strong initial symptoms. Like if you wake up and you're just like, oh my gosh. Thick yellow mucus, hacking cough, muscle aches, chills, just overall not feeling great. Now here, they can both have runny nose, nasal congestion, red watery eyes, and a loss of energy. A loss of energy is a little different than like the muscle aches. It just feels like you just feel crappy. So we're going to focus we're going to talk about allergies, allergic rhinitis, also known as seasonal allergies or hay fever or however else you guys have heard. Allergies. It's characterized by sneezing, watery eyes, and nasal congestion. You guys can get this also with animals. Anyone here have allergies? Yeah, seasonal, always. So, yeah. So probably some of you probably have food allergies. Some of you probably have pollen allergies, allergic to Utah in general. Well, Mark, sorry about that. Good. Are the shots working? I'm curious to know. Oh, good. Good. Sometimes, yeah, I don't know. You never know. Sometimes they don't work. Sometimes they do. So here's a little video about, and I hope you guys can see the notes on the PowerPoint. I try to put the link, try to make sure the link is under the notes on the PowerPoint. Pretty interesting. Okay. So allergic rhinitis, aka allergies, is caused by an exposure to an environmental allergen. Now, that could pretty much be anything. It could be just one thing. Like, for example, my husband is allergic to alfalfa. He can tell if we are within like 2 miles of a hay truck on the freeway. If it comes through, he immediate response, like it is crazy fast and it's really strong. So alfalfa gets him. He has other mild seasonal allergies, but that's the main one. Other people are really allergic to like multiple types of trees and flowers and grasses, and in Mark's case, all of Utah. So everybody's different. They have different allergies. It could be food too, animals, stuff like that. I think I had a student last semester who was allergic to just horses or something like that. Anyway, so everybody's different. Y'all have allergies, I'm sure, to at least something. So symptoms can resemble the common cold. We kind of talked about that. You can get the inflammation of the nasal mucosa. You can get like the sinus congestion. You can get the tearing, burning, red, swollen, or itchy eyes. And we all know that if you touch your eyes, it gets worse. Sneezing, nasal itching or congestion, postnasal drip, which can cause coughing, and if that cough persists, it can cause a sore throat too. So those symptoms can also mimic a common cold with the coughing and the sore throat, which can just be from the postnasal drip, right? So for all of you visual peeps out there, here is kind of a picture about exposure to pollen, and then the plasma cell releases the antibodies, and then they bind to the mast cell, and then the pollen comes and they release all these fantastic prostaglandins, great histamine, stuff, and then it causes all the symptoms. So there's your cascade. All right. Here's another one. This one's pretty short. I go fast. back in the game. That's what we want, right? Okay, so now we've done a quick overview of allergies and the cold. By the way, so talking about colds, we do, if you go in with like cold or flu symptoms or something, they'll do what's called an RFA. It's a, why am I drawing a blank? Respiratory film array. That's what it's called. And it tests for like 20 different viruses. There's like 4 different types of coronavirus. There's 2 different paraflu viruses. There's a couple of pneumonias. There's a whole slew of them. The most common ones. And a lot of times they'll come back with rhinovirus. And so you walk in and they're like, what's the test results? And you're like, you test positive for rhinovirus. And they're like, what? And then you always have to follow it up with, that's just the common cold. So the common cold usually is caused by some type of rhinovirus. But anyway, that's what it's called, rhinovirus. Probably what they have if they have a cold. But nobody knows it's the rhinovirus. So got to be careful when you tell people what they're positive with, because they'll, sometimes our, if you go in and you're like, you're positive for paraflu, or nowadays if they have coronavirus, you have to be like, okay, listen, you don't have COVID-19, you have a different type of coronavirus. And then it's like this whole explanation to calm their fears so they don't freak out. And that's like adults and children alike. Okay, so what type of medications are we looking at that are going to help us manage our allergies or treat our cold? A lot of times, they all have the same symptoms. Allergies and histamines, Mark, good. So allergies don't really have a cure. You can manage them, like Mark's taking shots. If he didn't take his shots, his allergies could potentially come back. If you don't take your allergy medicine in the morning, it's a short-term symptom management. And so is colds. Colds there's no cure for colds. So you're just managing your symptoms. And there's a whole slew of medications that can help you manage your symptoms. So that's what I'm getting at. Who knows what other medications, what other types of medications we can use to manage cold, flu/allergy symptoms. Yeah. Right, Olivia? Sometimes you gotta be careful and you gotta read their faces when you're like, it came back positive. You could just come out and be like, it came back positive with the common cold, which is caused by a rhinovirus, yada, yada, yada. So yeah, when you give them test results, especially for different viruses or bacteria, it's good to have a little bit of layman's terms in there. I can only imagine her being on the Instagram being like, oh my gosh, guys, I have rhinovirus. What am I going to do? Is it curable? And then you could be like, no, it's not. That would make her freak out even more. Anyway, yes, expectorants. That's right. Be like, you got at least, you got 7 to 10 days. That's what you got with this rhinovirus, 7 to 10 days. Leave it open like that, she'd freak. A lot of people would. Okay. How about decongestants? Or, on my list here, intranasal glucocorticoids, which I know when we get to the medications, a lot of you have actually heard these. You probably just didn't know they were intranasal glucocorticoids. Antitussives, decongestants, right? There's our antihistamines, expectorants, like Amy mentioned. Okay, so we'll go through. So here is a good slide that kind of puts it all together, kind of shows you what they all do. Okay, So we have the antitussives that suppress the cough. We have topical decongestants, which are like considered the nasal sprays. Those are, believe it or not, considered topical. Then we have our mucolytics, which we're going to talk about those here at the end of chapter 36 because they're different than expectorants. There really aren't they work in a different way. So keep a note on that. We have our inhaled corticoids, suppress inflammation. It just like tells you pretty much exactly what it does. Bronchodilators, mast cell stabilizers. Anyway, good picture. It has them all together and what they do. So I'm really bad at just talking. So, and then looking at the clock and being like, oh my gosh, we haven't had a break and it's already noon 30. So I've had these broken up just like this. We have our antihistamines we'll talk about there. Then we'll have the next section. So with every section, we're going to take a hot second and we're going to stretch and maybe stand up, right? Because it might be our last time online and I'm just barely like getting the hang of this. Okay, everybody stretched? All right. So there's two types of histamine receptors that we have. And we kind of talked, I don't know if we talked about it when we talk about NSAIDs or not, but we have our H1, which are located in our brain, our skin, bronchioles, blood vessels. And those are the ones that our antihistamines really work on. Then we have our H2, which is most in our gut. But know that we have two types of histamine receptors. We want H1, right? So drugs that block these receptors are called antihistamines. They are related to the structural form of histamine, but obviously they're not exactly the same, but they occupy the same receptor. So just like this, so here we have our histamine. That's what our body naturally makes. This is our medicine, this yellow one, and our medicine's going to come through and like, boop, stick itself on the receptor. So when the histamine comes, it's got nowhere to go. It can't affect anything. It's just going to not do anything, which is good because then our symptoms don't show up, right? It doesn't affect this, cell or organ or whatever to cause a runny nose or to cause nasal congestion or to cause my red runny eyes. Okay. But they don't block all histamine receptors. I'm sure even in this group, there are many of us that are like, allergy medicine works well for us. Like it definitely takes the symptoms down, but not completely away, right? So it's important to know they don't block all the histamine receptors. So we might have a tiny bit residual symptoms, but they definitely help. Okay, so antihistamines are split up into first generation antihistamines and second generation. There is a list of the first generation right here, second generation are under, I don't know if you can see that bottom piece. It's underneath there. So the easiest way to remember this first generation, second generation. Obviously the first generation came first. They were developed first, right? And then we're going to improve on it. And that's where we get our second generation. So our first generation could cross the blood-brain barrier. It caused lots and lots and lots of drowsiness. So we thought, well, what better way? Let's make some medication that doesn't make us drowsy. So we have our Benadryl, which is the most common first generation. It's in pretty much everything. We have our Benadryl, and we all know that causes people to be drowsy. We have our dimenhydrinate, which is the Dramamine. Who knows what Dramamine's used for? Ropheneramine, Dimetapp, promethazine, Phenergan, we all know that, hydroxyzine. So these are all first generation. These all cause drowsiness. Okay? So our second generation are our newer ones. Benadryl's been around forever. Our, great-great-grandmas know what Benadryl is. Now, our great-great-grandmas probably don't know what Zyrtec is, or Allegra, or Claritin. Those are relatively new in the last couple decades. So we have our cetirizine, fexofenadine, loratadine, levocetirizine, Izizol. There's also Clarinex, which I think is a levoloratadine or something like that. Clarinex is on here as well. These guys don't cross the blood-brain barrier, and so they have fewer anticholinergic symptoms, and they don't cause drowsiness. They're a lot less likely to cause drowsiness. So first generation causes drowsiness. Benadryl is your most famous one there. Second generation are considered non-sedating. Okay, so here's our drug slide for Benadryl. Benadryl is good for a whole lot of things. Sometimes it's not a good thing to have windows in our doors. Anyway, so it's antihistamine. It's an H1 antagonist, right? It blocks those receptors. Competes with histamine for binding with the H1 receptors. Causes drowsiness, huge drowsiness, obviously dizziness, and then it's got all your anticholinergic stuff. In some kids, it can cause nightmares, nervousness, and irritability. So one of Rachel's kids reacts to Benadryl that way. Rachel Walker, your other teacher. I don't know if you have her this semester. You did last semester, though. So contraindications, you gotta be careful with anticholinergic contraindications, right? You've got your glaucoma, your BPH, if they already have urinary retention, they're gonna want to be maybe not taking this because it'll make it worse. Acute asthma attacks, COPD, all that good stuff. Drug interactions, it makes you drowsy. It affects your CNS. So anything that's going to make that worse, any like opiates, benzodiazepines, any sleep aids, alcohol, that's going to just make it worse. So you're going to be careful with that. And then our nursing responsibilities. So you'll obviously want to assess congestion before and after therapy, make sure that it's working. Monitor pulse and blood pressure, maintain fluid intake, avoid driving, right? You don't want them to drive while they're taking Benadryl. They'll fall asleep. And then avoid all the other CNS depressants. Now, one thing to note, Benadryl is very helpful in a lot of things. We also take Benadryl for allergic reactions. More serious allergic reactions, like not necessarily anaphylaxis, because it's not as strong, not strong enough, I should say, for anaphylaxis, but you would use it as a follow-up to it. Like, you control the anaphylaxis, and then you're going to be throwing Benadryl on top of it. Also with that, you can can relieve nasal congestion. Why would it relieve nasal congestion? Anyone have any ideas? If you look here, it's kind of got all the anticholinergic stuff. Not necessarily considered an anticholinergic per se. But it's got all their stuff. What about this? Dry mouth. It dries you up, right? It'll help dry you up, so that nasal congestion will just get all nice and dried up. Rashes, itching, coughing, urticaria. Who knows what that is? Anyone? Anyone know what urticaria is? You're going to want to know what it is. Wink, wink. Hives. Amy, good job. You got it. It's hives. You get the itchy rash, raised welts, right? Good job. Also, Benadryl prevents motion sickness. If you go back to, we'll go back one. Benadryl helps. Also, dimenhydramate, Dramamine. Who's taken Dramamine before for motion sickness? These antihistamines can help motion sickness. Benadryl does as well. And it helps insomnia. That's down there at the bottom if you can't see that. A lot of sleep aids have Benadryl in them. That's what they are. Tylenol PM. You got your Tylenol, you got your Benadryl. A lot of those types of like nighttime meds have Benadryl in them. And that's why. It helps you sleep. Jessica, why? Just curious, what are they using it for in psych? Is it like to calm them down and get them to sleep? To plow people. I'm not familiar with the verbiage. So basically to calm them down and make them tired. Okay. Yeah, I can see that. I'll tell you, I have been guilty in giving my kids a little Benadryl when that's right. Victoria B52. I've been guilty in giving my kids Benadryl to help them sleep. So, kind of popular for parents to do that, like if they're going on an airplane ride or something, just so their kid will sleep through it all instead of scream and cry. I had, my daughter had, no, it was my son. So he had fallen and hit his head and he needed stitches on his head. And my mom's a nurse practitioner and stitches are her favorite things to do. So I called her up and I said, hey, I've got, this kid needs stitches. Will you come do stitches? She lives a half hour away. And so she was like, yeah, but I don't have anything. I don't know if I have anything to numb it with me. And I'm like, no big deal. I did not overdose him, but I gave him a bunch of Benadryl. By the time she was there, he was asleep and he slept through all of it. Kind of surprising with stitches, but he did like literally sleep through all of it. Benadryl is great. So why are antihistamines most effective if given prior to an allergen exposure? Gotta think like a nurse. Think like a nurse. Right, Megan, so it can block the receptors before the histamine gets there, right? So if you're allergic to dogs and you're going over to somebody's house who has a dog, probably a good idea to take some allergy medicine. And this goes for first generation and second generation. It's good to take it prior so that those receptors can get all used up with medicine that's not going to cause those symptoms. So when the histamine's released, it's got nowhere to go. Okay, it's not going to do any, not going to help anything, really. It's not going to cause any symptoms. There we go. So yeah, they're absolutely the best. They work the best if they're given prior to an allergen exposure. Obviously, we don't know when we're going to, we don't know all the times we're going to be exposed, but like I said, if something comes up and that you might have a reaction, good to have it and take it before. And a lot of those second gens, because they don't cause drowsiness, a lot of people just take them prophylactically every day. You might be one of them. Look, decongestants. Okay, everybody stand up, stretch. Oh, you get to see me dance. Just kidding. Do some jumping jacks. Okay, we're good. All right. Decongestants. Now, let me just preface, so antihistamines, this stuff, mostly for, it can, obviously, they dry you up, which is, let me just put that right there, breastfeeding right there. Contraindicated in breastfeeding. Number one, it crosses through to the breast milk. So your baby's going to get some of this medication. If it's Benadryl, you might not want them to be drowsy and sleepy because then they won't eat. Also, it has drying up effects. It causes dry mouth. It, the nasal congestion, it'll dry you up. So anyone who's breastfeeding, don't dry your milk up. Don't take those. Okay. And antihistamines don't work super great for colds. Other than drying you up, like if you have this crazy runny nose with your cold, you can take it to help dry you up and maybe to help you sleep. But other than that, colds don't really affect the H1 receptor. So it's not going to do a whole lot for colds. These are more likely going to be your people that are going to benefit the most, other than someone with cold. Okay. Sorry. Back to decongestants. Okay. So decongestants are sympathomimetics. So let's think back. What was it? 2 weeks ago. Sympathomimetics are adrenergic agonists, right? And they stimulate our sympathetic nervous system. Okay, so most of them are alpha adrenergic receptors. They cause vasoconstriction of the capillaries within the nasal mucosa. Okay, so that's how it helps. With in that video, it talks about the blood vessels dilating. When you dilate them, it causes them to be more permeable. There's more liquid going out of them. So you constrict those up. You make them nice and tight. They're not going to leak out any fluid. So your runny nose should stop. Your congestion should clear up. Okay. Comes in both intranasal and oral formulations. We've all heard of Sudafed. Please tell me there is not one person who has not heard of Sudafed. We all should have heard of Sudafed before, right? So Sudafed is one of these. We also have the nasal Afrin is one of them, right? Sudafed PE. So we have pseudoephedrine and then phenylephrine. They're very similar but different. Sudafed is the one that's controlled at the pharmacy. You have to show your driver's license. They keep track of how much you buy, when you buy it, stuff like that. Why? Because you can make meth with it. Just saying. For those who didn't know. But so that's why it's controlled, because it's one of the ingredients to make meth. But so good for nasal congestion. Okay, so one thing to note here. Oral formulations can cause systemic decongestion. Okay, so we take a pill, we put it in our body absorbs it, it goes everywhere. It's going to cause a systemic reaction. We're going to get vasoconstriction everywhere. Okay, whatever it does, it's gonna do it everywhere. So we're gonna get our systemic reaction to this. Okay. Obviously, if we have it everywhere, we're going to get more side effects, potential adverse effects. Okay. If we're just spraying this up our nose and it's just, like I said, it's kind of loosely considered topical. So we spray this spray up our nose. It's only getting onto our nasal mucosa. It's just going to shrink that up. It's not going to get us systemically. Does that make sense? So we have less side effects, less adverse effects if it's in one area versus our body absorbs it to the whole thing. I hope that makes sense and that you understand that. Wink, wink. Okay, so here's our famous Afrin, which works amazingly well. Okay, so these decongestants are only for people already experiencing symptoms. It's not a good preventative medication. So this is for something you wake up or you're going throughout the day and you're like, oh my gosh, I am stuffy. I can't breathe. I'm going to start taking medication, right? So already experiencing symptoms, okay? Really effective in relieving nasal congestion, especially with allergies or the cold. And then we talk about oral nasal preparations are available. Okay. Here's one of the problems with our intranasal sprays. They can cause rebound congestion. So, what is rebound congestion? It's a hypersecretion of mucus and a worsened nasal congestion once the drug wears off. So you take it and it works and then it wears off and your body goes into overdrive, right? Goes into overdrive. You have worse nasal congestion, worse symptoms, and it's the rebound effect. So this medication, any of the intranasal decongestants should not be used longer than 3 days. That's when you start getting the rebound congestion. So then what happens? People get this rebound congestion and they're like, oh, heck no, thinking maybe their cold's getting worse. So they use it more and more. Debbie's on here. Hi, Debbie.
Hello. I'll mute myself.
You're fine. So anyway, so they get this rebound congestion. They're thinking, I don't know what they're thinking. Maybe their cold is getting worse. It's maybe they thought, oh, the drug isn't working. So they start using it more and more and more, and they become tolerant and somewhat addicted to it because they need more and more and more to keep this nasal congestion away. But then when they stop, it gets so much worse. So something definitely to educate your patients on if they're searching for a decongestant. These types are really good. They're just, you got to be careful with them. So here's a slide that kind of goes over the pros and cons between systemic and nasal. So systemic, you take it by mouth, you get a systemic reaction, which can be good or bad, kind of depends on what you're wanting. It does relieve nasal congestion longer. It lasts longer than the topical nasal kind, but you get more side effects. So here on the other side, it's a nose spray. It's direct acting. You do get the rebound congestion if you use it too long, but it does have less side effects. So systemic, so Sudafed taken as a pill, is that maybe a good choice for somebody with hypertension? Probably not. If they're like, I need a decongestant, but I have some pretty good. Yeah, Megan, I can. So systemic is like your whole body system. So say you take an antihistamine, right? You broke out in hives. Or you went outside at dusk and you got bit by a ton of mosquitoes, okay? So you come in and you're like, oh no, mosquitoes, like I have bad reactions to mosquitoes. And you got a whole ton of them. So you're going to take a Benadryl. Now, Benadryl taken by mouth, it's going to go to your stomach. It's going to dissolve, get absorbed through your system. It's going to go through your whole system. It's going to cause you to be drowsy. It might have some anticholinergic effects that, dry you up, cause a little bit of urine retention. You're going to have all those symptoms because it went systemically. Okay. Now, say that happens again and you're like, wow, I remember when this happened last week and I took Benadryl and I got so crazy. I had all these side effects that I don't want, but I need to take care of these bug bites. So this time you decide, I'm gonna go topically, and I'm gonna get my hydrocortisone cream. And I put or even the Benadryl cream. They have Benadryl cream. So say you get the Benadryl cream and you're like, there's a mosquito bite, there's a mosquito bite, there's a mosquito bite, there's a mosquito bite. So you put it on to all your mosquito bites. That's going to be more direct acting. You're not going to get the systemic reactions that you would from taking the Benadryl by mouth. Does that make sense? Does that help? Okay, yeah. So you take anything by mouth, you're going to get a systemic reaction. If you have more direct, like the nasal sprays or creams, anything topical, you're going to get more of a direct acting.
Can I add something here, Corby?
Yeah, go ahead.
So real life scenario, guys, when you talk about systemic versus nasal, someone comes in with an allergic reaction, and I work in the ER at Ogden Regional. We see it all the time. We hit them systemically. So we don't just take it by mouth. We put Benadryl in their IV. Then we also do H2 inhibitors, which I don't know if you've gone over that yet or not, Corby. So we give them Pepcid IV. And so as well as epinephrine if we have to, if they're compromised in their airway. So when you talk about systemic, that's what we're talking about. It goes directly in the IV. It goes throughout the system, as opposed to someone who comes in and they've had a cold and they haven't, taken nose drops or anything of this nature to help with their respiratory issues. Does that help at all?
I hope so. Guys, I don't know if you've met Debbie. She is going to be a team teacher with me. So she's going to help me teach pharm. So hopefully what I get you confused about, she can clear you up about.
And vice versa. So it's me, is Corby helping me? So be patient with me. I'm a new person here. So,
So anyway, if you guys have any questions about pharmacology, you can, talk to either one of us. And if I'm confusing you, maybe go to her and she'll clear it up. Okay. So here's our drug information about Sudafed. Sudafed is a fantastic little med. It saved me many times. So it's a decongestant, considered a sympathomimetic. Okay, we've got our pseudoephedrine, right? Ephedrine or epinephrine is a sympathomimetic. Remember that? Okay, so we have our mechanism of action. Talked about that. So our adverse effects. So it's opposite. It stimulates our CNS, right? It's stimulating our sympathetic system. So we're going to get some excitability, maybe some insomnia, increased heart rate and blood pressure and blood glucose. So knowing that, patients that we need to be careful with taking this are people with hypertension, cardiac diseases, hypothyroidism, diabetes. So not necessarily meaning they can't have it. They just need to be really careful with it. They also have what's called a Coricidin HPB, which is a decongestant. HPB means high blood pressure. So people with high blood pressure can take that medication more safe than if they were to take Sudafed. Just a side note. Drug interactions, caffeine. Why do you think that would be a drug interaction? Because it's a CNS stimulant, right? Other sympathomimetic drugs. And then it antagonizes the effect of beta blockers, obviously, because beta blockers are adrenergic antagonists, right? And they're going to be fighting against each other. We have our adrenergic agonists, adrenergic antagonists. They're going to be affecting each other. Okay. So assess congestion before and during therapy, making sure that it works, monitor the pulse and blood pressure, maintain fluid intake. Somebody that's taking this medication because it can cause insomnia. Maybe not take it at night. However, Some people it doesn't affect. I took it at night and it was fine. I don't know. This was years ago, a few years ago when I was pregnant. When I get pregnant, I get nasal congestion like crazy. And so, yeah, Chelsea, sometimes it affects people that way too. Me, it didn't affect either way, but I can't sleep when I have stuffy noses, as if I have more than one. I can't sleep when I have a stuffy nose. So I would take a Sudafed every night. I'd sleep because I have a clear nose.
I just want to pop in here.
Yeah.
I don't want to derail or anything, but we have really smart people in here. Do you know the reason why Sudafed is behind the pharmacy, the pharmacist, and you actually have to take, that little card up to get it? Any ideas? Oh, you're so good. It is. It's meth, and meth will create. It's part of what it has to do to create methamphetamine, and all of these things are still there in terms of the what they do in terms of the adverse reactions, and they come in higher than a kite. They can't even talk. So think of that. If you're familiar with meth, if you've seen it, if you know anything about it, it's the same drug interactions and the same nursing responsibilities for that. And there's fake Sudafed. What's the name of that one? That's the one that's over the counter. Can you spell it? Phenyl something, yes. Phenylephrine. Yeah, phenylephrine is the pseudo Sudafed. So there's a difference.
Yeah, anything with this PE at the end of it, that means it's fake. Not fake, it's more like synthesized.
I love it.
Yeah, so anything with the PE under it. Also, with the whole meth thing, as far as I know, it takes 3 ingredients, and they call them the red, white, and blues. And Sudafed are red tablets, so that's where you get the red. So you need a red ingredient, a white ingredient, and a blue ingredient. Sudafed's the red one. Okay. So, any questions about decongestants or anything come up with antihistamines? All right. Oh, I'm turning the slide on the wrong screen. Here we go. Intranasal corticoids. So, let's stretch again. Woo, woo, woo. Oh. Debbie, I might just sneak a meth question in there when you're not looking. Okay, everybody stretching?
Oh my gosh, then I'll be in trouble. Okay, everything's fair game, guys. How's that? Everything's fair game. You have to know everything.
Debbie snuck that question in. Just kidding. Okay. Okay, everybody get up and stretch. All right. Now, back to intranasal corticosteroids. Okay. So we've already kind of talked about steroids before. I can't even remember what section that was in. What section was that in? We talked about steroids. Anti-inflammatories, right? Remember that? Guess what? Same type of thing. When applied, they decrease inflammation. Okay? So decreases the rhinorrhea, sneezing, congestion, reduces tissue edema, and causes some mild vasoconstriction. Okay, so corticosteroids, think of decreasing inflammation. Now, this is not the same type of inflammation as like you would see in like a tissue injury or something that you would use. What else? Like a immunosuppressed type person. Like it's not the same type of inflammation, if that makes sense. So these are your Pulmicorts, Flovents, Nasonex, Flonas's, they're really, really good for allergies. Okay. The problem with this is it takes a little bit of time for them to get working and to have the optimal benefits. They're not like the nasal decongestants. They don't work right away. You got to be taking them religiously for a while before you get optimal benefits. So somebody with, a cold, don't reach for the glucocorticoids. They're not going to work fast enough. You're going to be over and done with your cold before you're going to start seeing a lot of improvement there. Okay. These are really good preventative medications. Now, who remembers back when we talked about steroids, if you were taking them systemically, so if you're taking a lot by mouth long term, what do you have to do? And why? Do you guys remember? Taper the dose. That's absolutely correct. If you're taking them systemically for a long period of time, more than 2 weeks, you have to taper the dose. Who remembers one reason why? Anyone? Jessica, right, we talked about Cushing syndrome. So it'll affect our adrenal glands and cause them to atrophy, right? And they'll get all messed up. We'll be in a world of hurt. We want to protect those. So these are not systemic drugs, okay? They're intranasal. They're more of a topical, direct acting. So if you're taking these, if you're taking it for 4 weeks straight and then they go on a trip and you forget it and you're not taking it anymore, this isn't something that you have to worry about with these intranasal ones, okay? It's just the systemic ones. So you don't have to taper the dose on this. You don't have to worry about your adrenal glands. These are just direct acting right in our nostrils to help decrease inflammation. Okay. Most frequent adverse effects are irritation and a burning sensation immediately after spraying. And that kind of seems logical, right? You're spraying it up your nose. It can cause some irritation and some drying up. Sometimes people can get some bloody noses. Okay, so let's talk about real quick how to give these and this is any nasal spray, not just glucocorticoids, but any nasal spray. So we want to prime these suckers, right? Make sure they're working. Then we want to tilt our head forward a little bit, make sure that our head is kind of over our toes. And then we're going to point the nozzle tip toward the outside of the nose, right? We've got our poor little sensitive septum that goes right up the middle. We don't want to spray it into that septum because it's going to cause a lot more irritation than we want. So we're going to you don't want it pointing like this way, but more just towards the outside. Just avoid that spraying it right on top of that septum that we've got in our nose. And then you're going to spray it. Now, if you're taking these medications for nasal congestion, would it be a good idea to spray it in our nose and then go to the bathroom and blow our nose? Probably not. So best practice is if you're going to blow your nose before you use the nasal spray. Use the nasal spray and then don't blow your nose after, or you're just going to be blowing all that medication out and it's not going to work. Okay? If they have a bloody nose, don't give it while they have a bloody nose either. That's not gonna be fun. Okay. Any questions on those? Are these intranasal corticosteroids, are these going to be super great for a cold? I think I already kind of covered this. But just reiterating, these aren't going to be very good cold remedies.
And then maybe if I can pop in here and think about why that would be. So when you think about allergic reaction, okay, allergic reaction to pollen, allergic reaction to whatever, you have to go back to the disease process, okay? That means that the cells are releasing histamine because they view it as a foreign cell. And so that's what causes an over-release of histamine. That's why you have the swelling. So the steroids are helping reduce that swelling, but they're not going to do anything for the congestion and the reason why the nose is stuffy if it's not related to allergy. Does that make sense?
Perfect. Okay. All right. So sympathomimetics are the most effective drugs for relieving nasal congestion. We've talked about that, right? The nasal, like the Sudafed and the Afrin, they're like the best. But healthcare workers often prefer to prescribe antihistamines and intranasal corticosteroids. And I want to know if any of you guys have an idea why. Like, why wouldn't they just be like, you know what? These are the best. Just go get Sudafed and take it all the time. It's the best. Why would they go to these other types of medications? Megan, yeah, prevent the rebound. Those sorry, the comments threw me off. Prevent rebound, right. So those nasal decongestants like the Afrin and everything else, you can only use them for 3 days, right? So if we're using these, if we want to use these for allergies, we can only use it for 3 days. You better pick your 3 days wisely. Right? So antihistamines, intranasal corticosteroids, if you take them for seasonal allergies or animal allergies or even food allergies, depending on how severe they are, they will help prevent those reactions from happening. Plus, the sympathomimetics only work if you're currently having symptoms. Okay, antitussives. Woo woo, stretch again. Right, we're getting a lot of stretching in today. I'm making up for the other 3 weeks that we didn't.
And while you're stretching, I just want to address Mark's concern. There's different kinds of nasal sprays, Mark. We're talking about corticosteroids, steroid being the key word there. There's other types of nasal spray that are just saline, or they have kind of a decongestant in them. There's a bunch of different ones. But we're specifically talking corticosteroids in the reaction to the release of histamine. I just wanted to clarify that. Sorry. I'll be quiet again.
You're fine, Debbie. I love this. So I just want to interject one thing in here is with kids that have colds or allergies, unless prescribed by a doctor or you talk to a doctor, don't give them, I would steer clear from the steroids and the nasal decongestants, especially in babies. Do not use them. Okay. The best thing, like what Debbie mentioned, is saline, normal saline for babies for any congestion. Put the normal saline in, and then you can, let it sit there for a hot minute and then suck it out. These medications are not for small children unless directed by a doctor. Okay. Just want to put that out there.
Yeah, and again, why would it not be for pediatric use? Somebody can comment on that because you guys are like all super smart. Why would you not want to use corticosteroids in a pediatric patient? Go back to your nursing indications and your adverse reactions, adverse events. What's it going to do to them? Hello?
Bueller. So with just seeing with little babies, they're dependent nose breathers, right? They're dependent nose breathers. If they can't breathe through their nose, they've got a problem and you need to get that fixed. But if you start using those nasal decongestants on them, it'll clear them up but then they get that rebound. Not good. Like, not good. Then they definitely can't breathe, and you've got a bigger problem on your hands. So, especially with infants and those that are, dependent nose breathers, you don't want to put any medication up there. You just want to suck them out and give them a whole lot of fluid. Debbie, did you get your question answered? About not using it?
But that's okay. I mean, the same effect in terms of, we talked about meth, we talked about, things of this nature. You can't, it raises their blood pressure. All of those side effects are not helpful. And then the steroids, you're introducing steroids, which can immunocompromise them. And it's not good. It's just not good. That's the reason why you can't give ibuprofen to pediatrics for the first 6 months. You can't give a lot of medications because their systems just aren't advanced, and so you have to be very careful with that. So that's one of the things. And no, I don't know that this is going to be on the test, so don't hold me to it.
Kylie, yes, you're right. We're going to talk about those when we talk about our lower respiratory. Yes, but as far as using them for allergies, using the nasal sprays, the decongestants, any of these medications, actually, antitussives as well. We don't want to give kids antitussives either. They're used very cautiously in children. Also, with the nasal sprays, they're automatic, like adult doses, right? I don't know. Can you do like a fourth of a spray? That's going to be really hard to do. So as far as any of these cold and allergy medicines, especially, and unless you talk to a doctor, don't give them to kids younger than 2 years of age. Okay. Overall blanket statement for all of these meds. Kylie, where it comes in a spray, I
think sprays are pretty difficult. But for instance, there is a pediatric dose for a decongestant. Claritin. Claritin has an adult and it has a pediatric. Claritin, is approved for pediatric use. And so their concentration is different. And when you get into peds is its own world. So, be careful with that. We can go down a rabbit hole really easy with pediatrics.
Yeah, so always just, if you're counseling a patient or a family member or a friend or trying to dose your children yourself, really just follow the directions on the box. That's going to be your best bet unless directed by a physician. Okay, antitussives. This is cough medicine. Good old cough medicine. We love cough medicine. Okay, they're used to suppress the cough reflex in the medulla in our brain, right? That's our cough reflex. So, guys, the best antitussives out there are opioids. The best one is codeine. I'm just saying. They're the most effective. One thing to note, though, is if you're treating pain with an opioid versus a cough, your cough dose is going to be less than your pain dose will. Does that make sense? So lower doses of opioids are needed to get that cough suppressant than pain control. But thankfully, there are some over-the-counter kind. So in opioids, they act by raising the cough threshold in the cough center. So if you had a little tickle in your throat and that's making you cough, and you take this codeine or hydrocodone, which is also in Lortab and Norco, if you take that, then that little tickle, your threshold is going to be raised. So now that little tickle is not going to bother you anymore. And it's going to take more to get you to cough. Okay. So it acts by raising the cough threshold. Codeine is going to be the best. Hydrocodone is down there too. That'll help. So our non-opioids, obviously opioids are prescription, right? They're going to be our prescription ones. Our non-opioids are chemically similar to opioids. They do act on the CNS to raise the cough threshold. They don't. They're over the counter, so they're a lot safer to take. And you don't get the dependency and tolerance with them like you would with the opioids. Okay, so any type of antitussives are best for a non-productive cough. If you have a dry hacking cough, that's probably an antitussive is probably for you. Now, if you have a productive cough and you're coughing stuff up, you don't necessarily want to stop that coughing because you're getting stuff up. It's productive. Whatever shouldn't be down in there is coming up, and that's good. So these are good for non-productive coughs. Okay, let's see. So here we have our dextromethorphan, our Delsym. Anything with a DM after it is going to have dextromethorphan in it. So you've got your Robitussin DM or your Mucinex DM. Anything that has this DM, it'll have dextromethorphan and it has an antitussive in it. Okay. Benzonatate is fabulous. They are, here we go. I have it out of order. So we'll go here first. So benzonatate, they're called Tessalon pearls. They're little, like shiny yellow capsules.
Yeah, they look just like a pearl, guys. That's why they call them pearls.
They do. They're really cool. So these are prescription. They're really, really good for cough. They're not an opioid though. And it does have this works by having like a local anesthetic effect on it. So it doesn't affect your CNS per se. It just kind of like, you could think it kind of numbs the area. So you're like you're not coughing. It interrupts the cough message that your body's getting. So it affects the cough that way. So here's our dextromethorphan. Okay, I want to mention one thing, and I hope you guys are all listening because this is really, really important. Your book says that dextromethorphan is an expectorant. It's not an expectorant. It's an antitussive. Okay? It can be mixed with expectorants. You can have an expectorant and an antitussive together, but dextromethorphan by itself is an antitussive. So please, please make that note. Your book is wrong. Okay? So we talked about the mechanism of action, reduces the, that is an expectorant thing. I forgot to take that out. Sorry. Cross that out. Boop. I missed that. Amy, you protest. You need a reason to protest. There you go. The book is wrong.
And just to make matters worse, I'm going to be advocating for a new book. So there you go. You won't be able to sell your book to the ones coming in.
You don't give them this news now, Debbie. What? So Jennifer, a lot of books do come where you can download it online. Yeah, there's a lot of pros and cons to books versus apps. We won't get into it right now, but anyway, so it does cause some respiratory depression, so you got to be careful with that, right? If you overdose on it, you can obviously get toxic effects, right? Okay, one thing to note right here. Don't use it in kids less than 4. Typically, our kids are coughing for a reason. Okay, like our kids at that age, their body, they're coughing for a reason. So either they have an infection, they have something in their throat, they have something going on. We don't want to cover that cough, okay? Because if we do cover the cough, we could cause more problems than it's worth. So circle that, star it, arrow it, whatever you need to do. Remember that these are not used, this is not used in children less than 4. Look, I told you, every week we're going to talk about, like, it's going to come up somewhere. There it is, grapefruit.
Like grapefruit juice should be a controlled substance, truly.
It should. There is a drug, in at least one drug in every single, like, any lecture we have that says no grapefruit. So I don't even know why they keep growing it. They just need to, like, just, if anything should go extinct, it's the grapefruit. Okay.
For whatever reason, old people love it. It drives me insane.
And Chelsea too. Anyway, obviously, if you're giving this to a patient, you're going to want to make sure, monitor that cough. Make sure that the medication is doing its job. Monitor the lung sounds, right? If we're suppressing a cough that we shouldn't be suppressing, our lung sounds might get worse. Okay, so we need to monitor those lung sounds, make sure that everything's happening. If they're taking this and they start coughing things up, maybe they need to stop taking this, because coughing, as annoying as it is, it has a reason, and sometimes it's good and we want to cough. Okay.
And if I can just kind of intercede here, in the ER, we will prescribe this quite often. And because people come in and they're like, I hurt so bad, the muscles in my chest hurt so bad, because they're cough, 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 cough. And remember, we do have a glottal stop down at the back of our throat so that things don't go into our lungs, okay? Well, if you've got a sinus infection or something, that's dripping down the back, that's where it stops, and that's when the body goes, I'm not going down here. We give this dextromethorphan, we give Tessalon pearls, huge difference in the person 2 to 3 days later.
So very good for non-productive coughs, right? So when is a time, say we have a productive cough, think about it. Say we have a productive cough. We're taking expectorants, which we're going to talk about here in a minute. But so, it's a good productive cough. When is a situation where we might want to give dextromethorphan anyway, even though it's a progressive good cough? When do you think you'd want to give dextromethorphan, even when you have a productive cough? Think about it, guys. You guys are smart. You got this. Somebody give me an answer. Debbie. Amy, not the answer to everything. A lot of you guys got a test question wrong because y'all picked glaucoma. Kylie, you're right. When the cough is interfering with sleep, if you're coughing all day, say it's still a productive cough, but dang it, you've got to sleep. Absolutely take an antitussive so you can sleep. Yep.
I got it right too.
Yep. And Taylor, just like Debbie said, if you're just coughing way too much, you need to calm that down. Yeah. But most of the time when it's a progressive productive cough, the only time you really want to suppress that is when, so they can sleep. Okay, we talked about benzonatate, which is fabulous stuff. Any questions on expectorant? No, we're talking about expectorants. Any questions on antitussives?
I have a question. So I'd like some answers, not just from the few that are doing it, but what would be not nursing considerations? What would be nursing education? Because remember, guys, in pharmacology, you live in the world of education and adverse events. What education would you give to an adult who has a non-productive cough and has been prescribed dextromethorphan, or Tessalon pearls? Just a one-word answer or a short sentence. Okay, I agree. Increased fluids. Huge. Somebody else is typing. No grapefruit. Yes, thank you, Megan. Opioid, if it's an opioid, I would agree with that. We're talking non-opioid.
So drinking water, especially if it's a non-productive cough, drinking water will act as kind of its own expectorant, and you'll thin out that mucus, and you'll, if you're drinking a lot of water, you can turn that non-productive cough into a more productive cough because you're loosening that mucus. It's getting less thick, and you can get it out easier.
Yep, and I agree with Jessica. Don't drive if they had been prescribed an opioid. I agree with that completely. Yes, I agree that they'll still have a cough. It'll be less frequent. It shouldn't increase the coughing, Stephanie. It should decrease it. I agree in terms of getting up if you're dizzy, because they need more fluid. Remember, there's an infectious process going on here, and we characteristically don't drink enough fluid. So, yes, we're still talking about dextromethorphan. Sorry, I'll mute myself for me.
So it can have, just know that, all these medications, I know it does say this, and I'm going to address it. So all these medications can affect people differently. So it can, in some people, cause respiratory depression, especially if it's overused. Okay, so in abuse situations, the CNS can be, it can happen. If they're just taking it, short term as directed, you're not going to see a whole lot of that. That's kind of why they're under the side adverse effects. So yeah, so it can cause some respiratory depression if overused. And in, you always get those like weird people that, take a medication and they're like, oh, it made me do this. And you're just like, that's weird. So every once in a while. So let's see. I will fix this slide because a lot of I didn't even realize a lot of this has expectorant type stuff on it, and I'll fix this slide and send it out to you. Don't do it. There was that I was gonna say there was that cinnamon challenge too, and you guys talked about not taking spoonfuls of cinnamon. Don't do that either. Bad idea. These guys, these are all these challenges. Bad idea.
Yeah. So, and just remember, Benadryl, it does cause respiratory depression, but we see Benadryl overdoses quite often, and it actually has the adverse effect. It makes them nuts, and they'll get tachycardic, and instead of depressing, it actually makes them more, what's the word I'm looking for here? It's the opposite.
Anxious.
That's one of the reasons why kids don't respond well to Benadryl at times, because it can make them go, I don't want to say crazy. That's not right. It just makes them hyped up.
And we've had a couple of Benadryl overdoses on the pediatric unit, and I will tell you, they hallucinate like crazy, and it's sad to see, and it's really hard as a nurse to help control that. There's Benadryl overdoses. A lot of these medications don't have any antidotes. There's not really an antidote. You can, if it's taken and you get treatment quickly, you can take activated charcoal. They might induce vomiting potentially. But once it's in your system, you've got to ride it out, and it sucks. And Mapu, please tell me you did not try the cinnamon challenge yourself. You don't have to respond, but But yeah. Oh no. We all know kids in junior high make poor choices. It's fine. It's not you, it's your brain. It's just not fully developed yet. But anyway, yeah, there's a lot of better things to overdose on than Benadryl or Tylenol or ibuprofen or any of these other things. Okay. That probably came out wrong and sounded wrong, but we're going to continue.
For Corby, don't overdose on any of these things. Just saying.
A lot of these things, you just get like a long, I mean, if you take enough to die, it's a long, painful death. It's just awful to see. Anyway, expectorants. Okay. So these reduce the thickness and viscosity of the bronchial secretion. I'm sure with the big group of us, we could definitely have a great discussion on good things to overdose on, but I don't know if it's necessarily appropriate. So anyway, okay. So now we have this like thick, nasty mucus in our chest that we just can't get up. Okay. Expectorants are going to be our friends. Okay. Okay, so these are the ones we've all heard of. Mucinex. Who's seen? Let's see, this guy right there. Whoop, that guy. He's our big ball of mucus that we want to get up. He's camping out. I should have looked up some cartoons or some commercials. You've seen him and his family camp out down in the lungs, right? And he's not leaving. So we take an expectorant to loosen up that thickness, get rid of all that, like to just loosen it up so we can get it out. Okay. So this is a common ingredient in combination with multi-symptom cold and flu stuff. You can get it by itself, but most often you're going to see it with like any type of medication that says cold and flu on it, really. NyQuil, any of those generics, any of the cold and flu preparations, you're going to have an expectorant. You're going to have a, anyway, something for fever, something for cough, something for congestion, and an expectorant. They're all going to be in there in various doses, okay? So because they're loosening up the thickness, we want to hydrate. These expectorants, they don't work if you're not well hydrated, okay? Don't use them in children under 6. And coughing up phlegm is expected. Okay, something good to tell your patients, like, hey, I'm going to, you've got a lot of junk down there that's not moving. We're going to give you an expectorant. You will, once it starts working, start coughing up the junk that's down there. And it's a good thing. I mean, it's nasty and nobody likes it, but it's a good thing, right? We want that. We want that all cleared up. Okay. So they stimulate mucus flow, allow them to be removed. Here we're talking about guaifenesin or brand name Mucinex, which we've all heard of. Okay. All right. That was a short little there's really only one really good expectorant. What about antibiotics? Are they good to treat for allergies or the cold or the flu? I'm sick. I need an antibiotic. I don't feel good. I need an antibiotic. I think I have the flu. I need an antibiotic. Mark, maybe not the best bedside manner, but you could sugarcoat that. Hey, right, Megan, they're to treat bacterial infections. What causes the cold? What causes a cold? Is it a bacteria? Rhinovirus, right, Mark? Rhinovirus. It's a virus. We have antivirals, not for a cold, but These are antibiotics for bacteria. They're not going to do a single thing for allergies. They're not going to do a single thing for cold and flu. They're just going to give you diarrhea and maybe cause a super infection.
Just to kind of insert here, unfortunately, I'm old enough to remember I actually got a smallpox vaccination way back when. But in the 60s, I know I'm dating myself here. I was a kid. They gave us penicillin for every little sniffle. And that's what kind of started the bacterial resistance, because they don't work on viruses. But so many people will come to the ER or go to the doctor's office and they want pills to take care of their kid or to take care of themselves to get better, like right now. But so that's one of the reasons why we started the bacterial, the resistant bacteria, because we're giving antibiotics for the wrong reasons.
Okay, so if you have any questions on the test or otherwise that talks about antibiotics with cold and flu or allergies, just don't do it. Okay? Just saying. All right, any questions on anything we covered? Because I got a few practice questions, and then we can break for lunch before we go on to chapter 36. Bueller. I want to say that every time I'm waiting. Crickets. Okay, good. Let's talk about the practice questions. Okay. A patient is receiving an expectorant. We remember what those are, right? The nurse knows the drug is exerting its therapeutic effect when the patient experiences what? Okay, bronchodilation? No, not a bronchodilator. Decreased coughing. Actually, you take an expectorant, expect to cough more. I get it. Expect. Of course you do. Okay. Loosening of bronchial secretions. Yes, I'm in a weird mood today. I apologize. Relief of nasal congestion. No,
It's
doesn't
my
do anything.
fault. She's in a weird mood.
Relief of nasal congestion. Doesn't do anything with the Mark, surprisingly, I haven't had any today. Just kidding. I don't take it. What? Loosening of bronchial secretions. That's the correct answer. Moving on. Okay. A nurse is teaching an older adult patient about guaifenesin. Which information is appropriate to include in this teaching? Select all that apply. Take the drug with a glass of water. Read labels on over-the-counter drugs and check with healthcare providers before taking cold remedies. Take the drug at bedtime, or advise patient to contact healthcare provider if the cough persists more than 2 days. What do you guys think? A, take the drug with a glass of water, right? Guaifenesin is an expectorant. So, yep, we're gonna want to drink lots of water with it. It's not gonna work if it doesn't. You want to drink water to get that stuff loose. Okay, B, read labels on over-the-counter drugs, right? Because if you're just taking guaifenesin and she's like, oh yeah, I also need something for all these other symptoms, right? You need to be careful you're not overdosing. Take the drug at bedtime. Now, if you're taking something to increase those secretions and get them out, you're going to be coughing, and that'll keep you up. So not at bedtime. Okay, so what are your thoughts on D? Contact a healthcare provider if a cough persists more than 2 days. Anyone disagree with that? There's a lot of D's up there. Anyone disagree with D being an answer? Mark, it's probably 3 days.
I would disagree.
Okay, Debbie disagrees. I guarantee all of you guys have had colds. How long does your cough last? Do you get worried if you've been coughing for more than 2 days? Mark, it's like 7 days, right? You're coughing for freaking ever. And it never goes away until it does. So, right? So 2 days, coughing for 2 days, maybe not too worrisome. They don't really need to worry. Okay, so I would disagree that that's an answer. Kylie, for sure, coughing is so annoying, right? Nobody likes it. So a cough persisting more than 2 days, if that's not worrisome. If your friend calls you and says, oh my gosh, Kylie, I've been coughing for 2 days. Are you worried? Are you like, dude, Brooke, you should go to the doctor. If it's 2 days, you should go, right? Maybe Kylie, maybe you would be like, that's so annoying. Get that taken care of. But 2 days isn't concerning, right? So not necessarily. Now, if it said advise patient to contact healthcare provider if coughing persists more than 7 days and they're getting like nasty mucus up, yeah, that might be a little more concerning, right?
And I would also intercede probably if they start to run a fever, because then the infection process is different. But believe it or not, guys, we have people that come into the ER that have had a cough for 1 day and they're done with it and they want it cured. And I'm like, are you kidding me? So
just kidding.
It can make you go crazy, but your guys is right. 7 days.
So Fernando, coughing, excess secretions as a result of the med. That's kind of what we're looking for. So that's what we're wanting, is to cough up these secretions because of the med. We need to loosen it up, be able to get it out. Okay. Right. I have this tickle in my throat. I know it's something bad. Debbie, I'm coming to you to the ER.
And then you wonder why I get nasty. That's where you get your bedside manner, and you try and do, again, education, patient education on the disease and on the medication. You guys are awesome.
Yeah. So Fernando, good question. If it's continued beyond 2 days, if they're still coughing up phlegm and junk, that's okay. Like what Debbie said, if they're starting to get a fever, or if they're getting worse, say they don't have a fever yet, but they're clearing up all the junk, but they're getting sicker and sicker and sicker. You know, all those things are concerning. Just a cough persisting for more than 2 days. That's all your information. Okay, you guys can answer these questions with all the information there. Don't read into it. Don't be like, oh no, a cough persisting for more than 2 days with a fever and lots of secretions. Of course, that's important. Pick that one. Don't read into it. Just a cough persisting for more than 2 days. Think about it. Am I going to be concerned if a friend calls and says, I have a cough for 2 days? I mean, yes, I would want more information, but if that's all they gave, I'd be like, no, you're good. You know, give it a few more days. So, no, Fernando, you're good. You've got good questions. So, one of the big tricks of answering these questions, especially with nurses and how you guys are changing how you're thinking and the questions are changing how they're written, try really hard not to read into the questions. Just go with what they give you, and that's it. Okay? All right. We've been diagnosed, a patient has been diagnosed with a common cold. The nurse should question if which drug is ordered to treat this patient. So question doesn't mean like go crazy or freak out or just not give it. It just means maybe you should be like, you know, doc, is this the best idea? Debbie, go.
No, definitely.
Thank you. I get it.
But also think about it, guys. How many times do people go in with their kids for ear infections? And believe it or not, the most recent evidence is showing that most ear infections are, guess what? viral. And yet they want antibiotics. So be aware of that one.
Well, and it's kind of like as a society, we've been kind of unknowingly taught that, you know, an ear infection needs antibiotics, right? And don't, I don't know, like, I guess try to calm people down, or if people freak out at you, like, you know, right, oh, good question, Megan. So a lot of times the doctors will be like, you know, it's probably a virus, just, you know, go home. If it gets worse, come back. That's always kind of the gold standard with anything that's not concerning. They say, if it gets worse, come back. So Megan, viral or bacterial? Well, they do cultures and blood work, like the RFA I talked about. The RFA up your nose will come back and tell you what virus. So here's the problem is we can't, I mean, there are over like 40 viruses that cause the common cold. Can you imagine testing like everybody that comes in with a cough? That test would be astronomically priced, right? I mean, that RFA test for maybe 18, I think it's 18 viruses last time I counted, and it's over $700 to have it done out of pocket. So a lot of times they'll just kind of have you write it out. If it gets worse, and a lot of time, like viral, I don't know if I'm making any sense. Am I just like rambling on? Megan, with a virus, you're gonna see you can see a high fever. You won't. No. Okay, Debbie, straighten me out here. I'm getting all jumbled in my head.
And I apologize. We're going down a rabbit hole. So viruses, you're going to see the immune system is going to attack it, and within 2 to 3 days, you should see it better. If they start running fevers, if they're, you know, that's a whole different ball game. Like high fevers and ear infections are really, really painful. But most of the time, you would do the same things here if they're in the age groups. Decongestants, okay? It goes back to the physiology of their ear canal, okay? Their ear canal is pointed downward. So if they have a cough, whatever bug is in their throat is going right up to their ear. And so, you know, a lot of times they'll do throat cultures. And yeah, you have to make sure you're not, you know, you're ruling out meningitis. But we're just talking generally. Generally, a patient's been diagnosed with a common cold. Which one wouldn't you do? D.
Right. So Kylie, yes, meningitis, we have a lot of protocols if they come in with certain symptoms within certain times and it looks serious, we'll take cultures before giving any antibiotics. Not just suspecting meningitis, but there are a bunch of other bad bugs out there that will do cultures before antibiotics just to rule them out or to see what's happening. So really, the long and short of whether it's a virus or a bacteria, it's really hard to know. We don't have tests for every single one of them, and it just kind of depends on what you're presenting with, how your track is going, if you're getting worse, if you're getting better, if your body can handle it, if it can't. It's a whole slew. So, all right. Hope that cleared up a whole lot of mess that I made. Okay. Which medication is a first-generation antihistamine? Good. See, you guys got this. All these other ones, cetirizine, fexofenadine, loratadine, those are all second-generation ones, aka non-sedating. Okay. When teaching a patient about the use of nasal decongestant sprays, the nurse informs the patient that they are most effective and less likely to lead to rebound congestion when administered for how many days? Or less. I should put or less. Right. If you're using them for these amount of days, 10, 14, 20 days, it's going to be horrible to get off of them because you will not be able to breathe. for a long time. But yes, so 3 days you'll start, after about 3 days, you start getting that rebound congestion. Okay, let's see, this one is the last question. Okay. Before administering diphenhydramine to a patient, it is most important for the nurse to assess the patient for a history of what? Now, these are all really good, right? Do you want to know if they have an allergy to penicillin? Sure. Yeah, that's important. Do you want to know if they have hypertension? That's important too. Diabetes? Sure. I mean, these are all important. Look at this word right here. Boom. Most important. They're all important. They're all things you want to know. But if you could only know one thing, what would it be? Kylie, you got it. It's glaucoma this time. Not always the answer, but in this case it is, right? We want to make sure they don't have any glaucoma. These others are important to know, but diphenhydramine and the most important, glaucoma. Okay. Yes, and diphenhydramine has that anticholinergic effect. So it's gonna dry it out. It's gonna make this glaucoma worse. It's just bad. Yep, and because of the it's the pressure in the eyes. It changes the pressure in your eyes. Glaucoma is really, if somebody has glaucoma, you have to take eye drops and stuff, and it helps to regulate the pressure in your eyes with your, what is it? Is it called aqueous solution in your eyes? And with the anticholinergics, like we learned, it dries you up. It'll change the pressure. So, which is bad for glaucoma patients. Okay. Any questions? We'll take. I know, guys. It's hard. This pharmacology and all these meds, so hard.
And I find kind of interesting in here. Pharmacology is a hugely difficult course. It's probably the most difficult course that you're doing, and you're going to need to dedicate a ton of time from pharmacology. There is a lot of medications that you have to know, but you are the only one that might be between the patient and a grave. And it's going to be pharmacology. And so we're going to deal with some of these things. There was a suggestion to might have a little bit of extra help or like an extra review session that I would do. I'm not going to reteach what Corby does, but we'll talk about it. We're probably going to generate, I still have to talk to Corby about it. What do they call it? Confirmation pages? Is that a right thing here? Just kind of a review page of things to make sure, clarification. Yes, thank you. Clarification page or document to just make sure that you know this. You have to know what the drug does, how it does, what are some adverse reactions, and what do you need to do as a nurse to help educate the patient. And if you'll stay within those bounds, the things should be pretty straightforward. You're also going to, as you know, you have math questions. Those should be free points, people, free points. We're going to clarify in terms of rounding. So you'll see that, but you should not get any medication math problems wrong. But you'll have those. So anyway, things are coming down the pike. So we're probably going to do like a Survey Monkey to get your opinions on things on the course and some ideas to make it better that come from you. But you're going to have to do the work, meaning we facilitate your learning. So that means you got to come to class kind of having reviewed that information. And I know that's hard when you're trying to study the night before, but it's not unusual to study 10 or 20 hours a week on these things. You just went through, I think, the hardest exam, but everything builds on ANS. And so Yeah. So you might have to kind of separate yourself from your friends if you have a study group. If you don't have a study group, I definitely recommend that. You can do the what if scores. So, you guys are really smart. You can see where you're at, but it is the toughest course that you'll see. And it's not just here, it's next semester too. You'll have it in your RN program. And it's just a different way. You got to know a little bit of the disease process to understand how the medication interacts with that or changes that, and how to keep the patient safe and educate them. That's where pharmacology lives. And so the only reason that we're looking at doing an extra review session is because pharmacology is so hard. If you want this to be fair, because then people are like, well, we need one in med-surg, we need one in foundations and blah, 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 then we just won't do it. Does that make sense? Because you can either have fair or you can have supplemental instruction in pharm, because pharm is different. So you can put up what you think, what you want, and we'll kind of go from there. We want you to be successful. Corby puts huge amounts of hours into these presentations. I'm so impressed with her as a teacher. So, and then you gotta, then you'll have me. So, and the two of us will tag team, and we'll kind of go that way. So does that help things a little bit? Kind of in my mom voice. Sorry about that. I'll be quiet now.
No, you're fine. It's great. I do want to stress, though, if any of you guys are struggling with the ANS right now, like if you're like anticholinergic, oh my heck, I have to sit and try to remember, or what's an adrenergic agonist, and you're really struggling to remember that stuff, you need to take a step back and you need to go back and learn it, because it's not done. We're going to be talking about those groups and those drugs and those side effects for the rest of the course. If you guys feel like you need help or clarification, or you just need to have it explained to you again, like, come meet with us. We'll help you figure out ways to study. We'll talk you through it, stuff like that. Like, we want you to be successful. And if you have any questions or you're not grasping a concept, you really need to get a hold of that early, because it like Debbie said, it just builds and builds, and we're going to be hearing about it every single week. So please don't be afraid to reach out. I try to have an open door policy, and like try to make you guys feel like I am approachable. So I want you guys to succeed and to know your stuff and be good nurses and not kill anyone. And a good ANS foundation definitely helps.
Yeah. And use the resources that you have in the course. There should be like a blank concept map that kind of goes through adverse reactions, what it does, what it deals with, kind of patient education, nursing considerations, blah, blah, blah. I think that's in your pages on your Canvas. So print those out and use them for your prototype medications. Okay, so those are the ones that you'll be tested on, so that it kind of helps you study. Still, to this day, I can remember many of my concept maps, and especially like Cipro, and there's a black box warning. And when I talk about and educate about the black box warning, what's in my head is my freaking concept map from pharmacology. Okay. So, and we have some other games we're kind of getting together now that we'll be able to be together. It'll be a little bit better.
So Kylie mentioned those blue boxes in the book that talk about the nursing diagnosis and drug samples. Mark, you want some of those? So for those who don't open your book, which I hope is nobody, right here. Here's one right here. I know the camera's funny, but it's these blue boxes, and it comes up nursing process. That's what they are. And it talks about what type of drugs you're talking about, and it goes through everything: your assessment, your nursing diagnosis, your goals, your planning, nursing interventions, and then patient teaching. And even it goes over even cultural considerations. So those are really, really good. And a lot of the information is on the test comes from those blue boxes.
There you go. That's your big hint for the day. And really, you guys should be living in those blue boxes. There's your hint. Hint, 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 hint. So it's different than just regurgitating information. If you remember biomed or anatomy and physiology, you lived in regurgitating huge amounts of information. This is now taking that information, like from your pathophysiology, and applying it. Okay, so here is this drug. What does it do? And what can I tell my patient? How do I educate my patient? As a nurse, what do I need to be aware of and look out for? Okay, it's taking that information and applying it. It's a higher level of thinking, because guess what, people? When you're out there and you're taking care of your patient, you have to think. And I know that you hear it, think like a nurse. This is how you got to get to that point. So it's taking that information and applying it. And that's why the questions are a little bit like not necessarily straightforward, because you have to think before you answer the question. Does that help at all?
Okay, fantastic. Okay, so let's do lunch. We'll get back at, should we say 12:35. Stretch, do jumping jacks, get something to eat, increase that blood sugar, and we'll see it at 12:35.
Bye.
All right. So we talked about all the upper, let me turn on my camera so you guys can see my arm movements. Okay, so we talked about all the upper respiratory stuff. Now we're going to talk about the lower. And this is like COPD, asthma, stuff like that. So real quick, I know we talked about it a little bit in the last, earlier this morning. So the lower tract, we have the bronchioles, we've got the alveoli, got the lungs, right? Okay, so the regulation is determined by two branches of the autonomic nervous system. They're the ones that help us breathe, right? So we have the sympathetic, which we talked about with the bronchodilation. We have the parasympathetic with the bronchoconstriction. Between those two working together, we're able to breathe appropriately, right? Okay, so bronchoconstriction is, bronchoconstriction is a common indication, is a common reason why we use meds, right? There's bronchospasms, maybe there's secretions or mucus plugs in the airway, edema caused by engorgement of pulmonary blood vessels, like with the pulmonary edema. So there's a lot of reasons why we use different pharmacology to treat our lungs, and they're kind of important, just a little bit. A little important to keep our lungs healthy. So your book mentions this, so doesn't go into a whole lot of detail. It does mention it, so I wanted to mention it here. Restrictive lung disease. So what that is a decrease in the total lung capacity. Okay, and it can be a lot of different reasons. You can have the pulmonary edema, pulmonary fibrosis, pneumonitis, loss of elasticity, myasthenia gravis. You can get it with that. Tumors, anything in there that's going to restrict your total lung capacity. So here's kind of a visual. Here you have your normal lung, Here you have a restricted lung. There's not as much capacity to hold air in this restricted one as you do with a normal one. Now that's different than, say, somebody with asthma or COPD or anything like that. They have normal lungs. Their lungs are just sick. They're not necessarily restricted in the capacity. Hope that helps. So, COPD. Good old COPD. So, a couple of disorders are classified under COPD, and they're chronic bronchitis, bronchiectasis, emphysema, and believe it or not, asthma. One thing to note is asthma is the only one under this, the bronchitis, bronchiectasis, emphysema. Asthma is the only one that is reversible in its damage. So you have an asthma attack, you get sick, your lungs are hurt, they're inflamed, something's happening. You can recover from that, and it's reversible damage. These other ones, emphysema, the chronic bronchitis, those are chronic conditions. Okay. And they all kind of overlap here a little bit. You can have, here's this Venn diagram again, right? And they all kind of just overlap, and the whole umbrella thing is like the COPD. Here it is again. This has a little bit more of symptoms that you can throw in that Venn diagram. So COPD is a persistent inflammation of the airway where you get large amounts of thick and sticky mucus. The alveoli are damaged. They've lost their elasticity. They're loose and flabby. They're not, blowing up like those beautiful balloons that we want them to. It's progressive. It gets worse over time. And the symptoms of COPD never go away completely, even with drug therapy. Drug therapy will help it, but it doesn't cure it, and it never goes away completely. So there's a lot of different drugs we can use to treat COPD. We've got our bronchodilators, our expectorants, right? It's got the thick, yucky mucus. Long-term oxygen therapy. Now you got to be careful with this because COPD is their receptors have changed. So, right, healthy people get their drive off of their oxygen level. COPDers get their drive off of their CO2 level. It's changed in COPD. So it's not always a bad thing if they have some low oxygen. If you walk into somebody with low oxygen that has COPD, you don't want to throw on a whole bunch of oxygen. This should all be review, hopefully. So be careful with the oxygen and how much you're giving them and what their oxygen levels are. Leukotrienes, which we're going to talk about. We're going to talk about steroids. We're going to talk about some mucolytics. And then some antibiotics, depending on what's going on with their lungs, can help treat this with the COPD as well. All right, asthma. Stretch. We just started. Okay.
Can I jump in here, Corby?
Yeah.
Sorry, guys, I'm eating my lunch. Just kind of a little bit review of COPD. They are always, if you consider a cliff, people with COPD are always on the edge of the cliff. And so one little thing will send them over the edge. And a lot of times they won't come in until they're practically needing a ventilator, for crying out loud, because they think, oh, well, I don't feel good, I'll get better. And so when you talk about the long-term oxygen therapy, then they call the ambulance. The ambulance floods them with oxygen. And so then the body goes, oh, I don't need to work hard for this oxygen. And they tank their saturations. So most of the time, COPDers will go anywhere from 88 to 92, right in there. And usually 2 to 3 liters is about all that you need. But if you flood them with like a non-rebreather, or you flood them with oxygen, they will tank their sats down. So when you're going into these rooms and they're on COPD, they're going to have big barrel chests and they're not going to breathe easy because they've lost the elasticity to do that. and they're over the edge. Does that make sense on the cliffs?
Yeah, thank you. Yeah, so you got to be careful. Another reason why it's important to take a medical history and know what's going on with your patient before you run in, because their SATs are 85. Okay, so here we talk about asthma. So asthma, here's our normal bronchial, right? It's beautiful. We've got this fantastic airway. Smooth muscles are working. We don't have much mucus in there. It's fabulous. We can breathe good. Well, now we have asthma and an asthma attack, and we'll talk about what causes that in a minute. So we get inflammation. So now we have inflammation, and our mucus has doubled, tripled. There's a lot of stuff in there, right? And we get bronchoconstriction. So not only do we have a lot of now mucus and debris that we have to breathe through, now our muscles are like, yeah, no, they're tightening up, which makes matters worse. It makes it really hard to breathe. Okay, so that's what happens in an asthma attack. Your lungs just kind of whoop, and then there's inflammation, swells up, constricts, the muscles constrict, and then you get a bunch of mucus and debris in there. And it's just a natural reaction that our body has. So chronic inflammation that occurs when potent mediators, we're going to talk about what those mediators can be. These mediators of the immune and inflammatory responses, they're released by mast cells lining the bronchi. We talked about the mast cells. The allergies come in, they release all this stuff, and it increases the mucus and narrows the airways and makes breathing more difficult. And the body just doesn't know it's doing itself an injustice. So we need to help it. Okay. So most people have intermittent and reversible episodes. They'll get something, a lot of kids, when they get a cold, that'll trigger their asthma. And it's not all the time. Like COPD is all the time. They're dealing with COPD all the time. It doesn't get better. Asthma, you just have what they call them exacerbations, where they're fine, and then they get this big asthma attack, and then they get over it, and they're fine and fine and fine. The damage can be reversible, stuff like that. Only the airways are affected, not the alveoli, which is a little different than with emphysema and the severe COPDs. Okay, you have the bronchoconstriction of the smooth muscle, inflammation of mucous membranes, and then you can get the mucus plugs. So that would be nice to breathe through. That would not be so nice to breathe through. That's where you get the wheezing, by the way. It's like whistling. Your lungs are whistling because they're constricted. They have a little hole that this air can go through. So your lungs are whistling. That's where you get the wheezing. So go ahead.
Also on the wheezing, sometimes when you listen to them, they inhale. As you inhale, you'll hear the wheezing, but you won't hear it on the exhale. That kind of tells you where the situation is. So if they're inhaling and you hear the wheezing, it's in the bronchioles. If they're exhaling in the wheezing, it's down in the bases. FYI.
Good to know. Okay. So triggers of asthma. There's so many different triggers, and as I say, everybody's different. So air pollutants, lots of different air pollutants. We've got the tobacco smoke, the ozone, the forest fire smoke, right? Oxides, fumes from cleaning agents, burning leaves, any type of air pollutants, cars. Some people that have really bad asthma can't live in a city because it's too polluted, and they just have asthma problems all the time. You can get allergens from nature. So you've got your trees, grasses, weeds, animal, the household dust, mold, chemicals in foods, chemicals such as medications, drugs such as aspirin. See that? Wink, wink. Ibuprofen, beta blockers. We talked about beta blockers and asthma, right? They don't usually go together. They can, depends on the person and the severity of the asthma, but things that you have to watch out for. Okay, foods, nuts, MSG, shellfish, dairy products. Kind of depends on what you're allergic to. Respiratory infections, bacterial, fungal, viral, colds are huge, especially in kids. A kid will get a cold and they might be hospitalized. And, you come in and you say, yeah, your RFA says that it's rhinovirus. And they're like, just the common cold. But these kids, it really takes down their lungs, like bad. And so, sometimes these kids just from a common cold will get hospitalized. Stress, also emotional stress, anxiety, pharmacology courses, and then exercise. You like how I threw that in? That was fun.
Yeah, that's so true. So I have a daughter that played volleyball for Utah State, and before that she was up in College of Southern Idaho, won a national championship there. She has exercise-induced asthma, and so she had to take these medications in terms of a corticosteroid when she was in season, as well as her inhaler, and we'll get to that because that's part of the treatment. When she wasn't in season, she had no problem. But you put the body under stress, either emotional, physical, and it can happen very easily. In fact, some of you may have even had or have exercise-induced asthma.
Yeah, so there's a lot of things that can trigger asthma or this inflammatory response. It's good also, I know at least for Intermountain, anybody that comes in with asthma, they have an asthma questionnaire that they have to fill out. And it goes over like, how are your symptoms? How have they been in the last month? How have they been in the last year? That gives us an idea of how well their asthma is controlled. And then also it goes over what's happening when they most often feel their symptoms, and then what triggers it as well. So it goes through everything, and it ends up in this asthma action plan, and it just helps us kind of, moving forward, helps them to help us, help them to help control this asthma better so that they don't have these exacerbations. Okay, so symptoms of asthma, you can probably guess. You're going to get coughing, you're going to get dyspnea, chest tightness, and then the whistling or the wheezing. Okay, those are the physical symptoms. Bronchoconstriction and bronchospasms, that's what's kind of going on physically. But they're gonna be coughing a lot. If you can't breathe, your body's like, something's wrong. We got to clear out and make sure everything is clear so we can breathe. So coughing is big, dyspnea, chest tightness, gasping, stuff like that. And then we have status asthmaticus. It sounds a lot like status epilepticus that we talked about, right? Both of them are life-threatening. This is status asthmaticus. This is just an absolute severe, prolonged asthma that just is not responsive to any drug treatment. They're having a crazy hard time breathing. It can be scary, and it definitely needs emergency care. Debbie, have you cared for status asthmaticuses before?
Oh, yeah, definitely. And it is a true emergency. And so most of the time they will come in by ambulance, and we try to give them oxygen, like on a CPAP or a BiPAP. Most of the time, depending on, and of course, we're giving them these medications that we're going to talk about systemically. And if they don't clear up, we intubate them very, very quickly because they do go into respiratory failure, and there is no way that they can maintain their airway and have the proper perfusion. It's all about inflammation. It's all about bronchial dilators. It's all about steroids. And if they don't respond, we intubate them, which is a tube that goes down through their throat, and we actually mechanically breathe for them.
Yeah, and it all happens very quickly because how many minutes can you live without breathing? Not very many. I heard a thing the other day, and I knew this information, but they put it in a way that like, oh yeah, that makes sense, and I can remember it. It says to go by the rules of 3. So you can live without water for 3 days, you can live without food for 3 weeks, you can live without air for 3 minutes. So kind of interesting. So yeah, this is definitely emergency, and it's like gotta be quick. And we'll talk about how to treat that. Okay, so these are the type of medications what we're going to use to treat these. We have the short-acting beta adrenergic drugs. I'm telling you, you're not getting away from this adrenergic, cholinergic stuff. Anticholinergics, you have xanthines, and we have our inhaled corticosteroids, anticholinergics, long-acting beta adrenergic drugs, mast cell stabilizers, and leukotriene modifiers. I know it sounds like a lot, but hopefully we can break this down so it makes sense and it's a little easier for you to remember.
And remember, these are families of drugs. So can you go back to that other one? So when you look at the prevention of the bronchospasm, the termination of the bronchospasm, those are 2 different kinds of drugs, and these are the families of the drugs, okay? So one prevents it or reduces the threshold, the other terminates it by dilating the actual areas of the lung.
Right. Okay, so let's talk about our sympathomimetics. What are these drugs doing? They're activating our sympathetic nervous system, right? And what does that do? That's our fight or flight. So these are going to be bronchodilators. These are going to dilate our lungs. We want, as we're running from the bear, we want to be able to breathe really big breaths. So it's going to bronchodilate. And this is our good old albuterol. This is called a short-acting beta agonist, or in slides to come, you'll see it referred to as a SABA, short-acting beta agonist, SABA. Okay. This is most frequently prescribed in an acute asthma attack. It's really fast-acting, and really quickly starts to work, and the effects last about 2 to 6 hours. Okay, so this is our albuterol or metaproterenol. That one's not used quite so much. It's usually the albuterol. This box right here, this is a box for a nebulizer albuterol in like little bullets, what they call little bullets. This Proventil and ProAir usually are meter dose inhalers, but it's all albuterol, and it's considered a rescue medication.
So I'm just going to jump in here while Corby clears her throat from her bronchospasm. And so remember, okay, your sympathetic nervous system, what's that going to do? Okay, it's going to dilate things. It's the same thing with this albuterol. So what would you expect to see? If you were running from the bear, you're going to, your pulse is going to go faster, right? Everything dilates. And so it's the same thing with these medications. So think about that when you say, okay, this is sympathomimetics. Oh, okay, this is fight or flight. Okay, I'm going to expect to see, these things. What's the eyes going to do? What's the lungs going to do? What would you see in that fight or flight? And albuterol is also known as the rescue medication. So if you think back to my daughter, every time she, right before she went into the match, her inhaler was there, and she would take a couple puffs of the inhaler. But when you get back into the corticosteroids in terms of the prevention, she took a steroid every day while she was in training, while she had a season, but didn't when she was out. And so there's a difference. The steroids aren't going to prevent it. Well, they're going to help prevent it, but they're not going to rescue if you're in it. in asthma. Does that make sense? Let me know in your comments.
Sorry, I lost my mouse. Okay. So this one, because it's an adrenergic agonist, we have these. Sorry. So if we go back to our sympathetic nervous system, right, we've got what receptors does it affect? It affects the alpha 1, beta 1, and beta 2. Okay. And albuterol is a selective medication, right? So it's going to select on that beta 2 receptor. So these, it stimulates the beta 2 adrenergic receptor in the lungs, relaxes the lungs so that they can dilate. They're not constricting anymore. Here's all of our sympathetic adverse effects, right? The tachycardia, the nervousness, the insomnia. They're gonna like tremor. They're gonna have these cute little shaky things because they're hyped up on albuterol. Okay, contraindications as always. Drug interactions, it's the same. Caffeine is on there again. The same with any other sympathetic agonist. It's going to stimulate that. Okay, so nursing responsibilities when giving albuterol. You want to make sure that you assess the lungs before you give it and after you give it. That way, I mean, then you can tell if it's working, if they need more. You can assess like what the lungs are doing and how they're sounding. So make sure you assess the lungs before and after any inhalant they're going to take, especially rescue one. Monitor pulmonary function tests. Monitor for any paradoxical bronchospasms. That can happen, so you just want to keep an eye on that. Albuterol also can, it raises the blood sugar and it drops the potassium. So, if they're on a long-term albuterol, you want to make sure that you're monitoring those things. Okay. And then also monitor the heart closely. Now, we talked about previously, and I talked about that it is a beta 2 agonist, but it can affect that beta 1 as well. So that's where you get the tachycardia.
So I have a question. So do you guys in PN2, do you learn how to do albuterol treatments through the use of the SVNs, small volume nebulizer? Do you guys do that? Am I making sense? No one's responding. Is it? Okay, so you need to make sure that when you are giving a nebulizer that you have, because the albuterol comes in a pre-measured dose, but if you're using, you have to make sure you have at least 3 to 4 mLs in that little area, because if you don't, then when you turn on the oxygen or the air, which has to be at least 6 liters, you're not going to aerosolize the medication. Does that make sense?
Oops, sorry. Hold on. I got a picture of that. What you're talking about. Right here.
Right. So down, yeah, that's right where that little blue area is where the medication goes. And you have to have at least 3 liters, 3 mLs of fluid in there in the medication. And so you might have to add like a little, we call it an NS bullet, to make that 3 mLs. And then you have to turn on the oxygen or the air to at least 6 liters to be able to aerosolize or to create that mist for the treatment. Those are 2 important keys, 3 mLs and 6 liters. Has nothing to do with what this medication does. I'm just trying to help you with your skills. And I'll be quiet.
No, you're fine. And this picture kind of cuts it off, but they're like right here, right where it cuts off is going to be the tube that's just like the tube for a nasal cannula that'll go into the wall. So that picture cuts it off, but that's where the tube would start. Anyway, it's kind of cool. Back to, I don't even know what slide I was on. Okay. So you'll want to monitor the heart rate closely. Now, what I want to kind of get across is that a rapid heart rate, where you look at the heart rate and you're like, holy cow, it's 135 beats per minute. That's good for me and you and Debbie. You know, that's a good solid tachycardic heart rate. Now, knowing that this patient is on albuterol, is it alarming? No. You know, what's alarming is them coming in and walking in and having a, 150 beat heart rate just standing there. That's a little alarming. But knowing that they're on albuterol, we know that it's going to make them, shaky. We know it's going to cause these types of things. We know they can get tachycardic. So, you're going to want to monitor it closely. You're going to want to chart it, of course. But is it something to, call the doctor about? Not necessarily. Just know it's going to happen.
Just an FYI on that. So when do you think it might be a problem in terms of how high would the heart rate needs to be that it would be a problem? And you can record that in your comments. But in the ER, we measure, so we can still hit them with 2 and 3 albuterol treatments until their heart rate goes way too high. What amount or what heart rate would you think that would be at? What number do you think? It's not a wrong answer. Just throw it in the comments and I'll come back to it.
I'm going to say like 160. But I'm with Olivia. 160. I don't work ER, so I'm not, and I'm used to the kids. I'm used to them being like, 200. So as far as an adult, I'm guessing 160.
I'll come back to that.
Okay. She's going to leave us hanging. All right. So, all right. So we've got our short acting, right? And I thought I had it in there, but I don't. Let's go back real quick to the status asthmaticus, where it's an emergency thing. You know that a lot of our emergency drugs are sympathomimetics. So if somebody comes in with status asthmaticus and, maybe they were taking albuterol at home and it's not working, what else do you think they could give in an emergent situation that might help? Besides the oxygen and intubation and stuff, what else would you expect them to be giving to help out with that? Amy, don't question your knowledge. You know it. You got it. Epinephrine. That's a really strong sympathomimetic. Okay. So we have our beta adrenergic agonists. Okay. So these are our long-acting beta agonists. These are our LABAs, L-A-B-As. You'll see that later in the slides. But these are not used to terminate a bronchospasm. These are preventative. Okay. They take 20 to 60 minutes to act. You don't want to be in an asthma attack for that long trying to wait for these to start working. Okay. They're used in combination with inhaled corticosteroids for the prophylaxis of persistent asthma. So this is our sympathomimetic that's used for prevention. It's our long-acting one. Okay. So like our albuterol, where it's only lasts 2 to 6 hours, these ones you're going to take maybe twice a day. Okay, so they're long-acting. So here we go. There's our SABAs, there's our LABAs, pros and cons. So here we've got albuterol. It's effective in stopping an asthma attack. Or They call them the rescue inhalers. So a lot of times when you feel an asthma attack coming, you can hurry and take it, right? And it might help fend that off. It's not going to prevent it per se, though. You have to be kind of actively starting an asthma attack. Only lasts 4 to 6 hours. Only effective with acute episodes. And like I said, it's a rescue. It's a rescue one. Now here we have our long-acting beta agonists for prevention. They don't have any value in an acute attack. You don't want to wait that long. It's referred to as a controller drug. So we're going to control our asthma, right? Prevent it. Works the same way as the short-acting, but it takes longer to work, okay? And then it's got to be taken daily, even on days when no symptoms are present. That's what a controller does. You could argue that a second generation antihistamine is a controller drug because you're still going to be taking it even when you don't have symptoms for your allergies to help prevent them, right? So you're preventing asthma attacks.
Okay, so I'm going to jump in for just a second. Can you go back to that previous one? So, okay, so here's the answer to the question. So 170, yeah, 180 is that. Okay, but remember, anything over 150 is classified as supraventricular tachycardia, right? Anything over 185 is like VTAC, okay, ventricular tachycardia. So remember, the heart's not doing well. So if you use your inhaler, and they were at 70 or 90 beats a minute, and then this is adults speaking, and then they use the inhaler, and now they're up to 160, and they only had one treatment, you're done. So we do it until they get to that point, and then we will try and do other inhalers or other where the epinephrine, because there's a thing called racemic epinephrine that we give, and then if not, they're intubated. So there's the answers.
Awesome. And they do have medications. It's called Xopenex, which isn't the first choice in an acute asthma attack, but it's really good if you get a patient. We've had kids come in and we're giving them doses of albuterol, and their heart rate just kind of climbs and climbs and climbs. So a lot of times they'll just even out and it'll just be tachycardic and even out. But sometimes they'll just climb and climb and get higher and higher and higher. They can give what's called Xopenex. That's the brand name. The generic is levalbuterol, and it works very similar to albuterol, but it doesn't have the tachycardic effect on that. So that's not really covered in your book, Xopenex, but just know that there is a medication like albuterol that doesn't raise the heart rate. Okay, anticholinergics. So these are our drugs working against the parasympathetic, right? So they have sympathetic type properties. Got it? Like I said, if you're struggling with the ANS that we covered a couple weeks ago, you want to go back and study that so you can keep all this straight. Okay, so here's where we get into our, sorry, I shouldn't have prefaced it with all of those words. Let's start here. Inhaled cholinergic antagonists or anticholinergics, right? They have all those different verbiages that mean the same thing. So these are bronchodilators that blocks the parasympathetic, right? Because we're sitting, we're resting and digesting. Our lungs don't need to be dilated or anything, so they just kind of go back. And these block the PNS and allow the norepi and the epi to activate those beta-2 receptors and dilate our bronchioles. Okay, these ones also bind to the mucous membrane receptors a little bit to help decrease the airway secretion. So you kind of get a twofer with these ones. These ones are only inhaled only. Albuterol epi, those that have different, like you can take an oral albuterol, stuff like that. These anticholinergics, they're only inhaled. You can't get them any other way. Okay. Adverse effects, cardiac dysrhythmias, chest pain, and then they leave like a bitter taste, which nobody likes, but it's not life-threatening in any way. So we have the tiotropium, which is a maintenance drug for asthma and COPD. And then we have the ipratropium. I practiced that word, by the way. I still can't get it. Ipratropium, which is a treatment for acute asthma, and a lot of times you'll see it together with albuterol, which is called a duoneb.
And that's very common in the ER. That's the first thing that we do. Remember, now these sound a little confusing because they're kind of doing the same thing. But again, there's a difference between systemic and direct action. So because these are only inhaled, this is the direct action. It's directly on those bronchioles, okay? And then the other ones that can be given, you know, in a different form is the systemic. Does that make sense?
Yep. So you can kind of picture these kind of like how we talked about the nose spray is kind of like a topical. This is kind of the same thing. It's kind of a topical for the inside of your lungs. If that helps. Keep the systemic versus the direct acting. Okay, so this is really, really effective with albuterol. Like I said, it's called a duoneb. So you're getting two different, if you think about it, you're getting two different actions, even though they're kind of doing the same thing. So you have one that's ramping up, you know, those beta 2s, your sympathetic nervous system. It's ramping those up and dilating those bronchioles. Then you have your anticholinergics that's suppressing the parasympathetic. Does that make sense? So it's doing the same thing two different ways. So you have one that's, you know, exciting the, you know, it's ramping up that sympathetic. You have one that's suppressing the parasympathetic. So that's why they're so good together. You have two different mechanism of actions doing the same thing. So here's your tiotropium. Causes bronchodilation by blocking, you know, the muscarinic receptors of the parasympathetic. You're going to get those same side effects potentially. Now, it does, like Debbie said, we get far less sympathetic effects. But if you're giving high doses of this to try to control, or, you know, if the patient's needing high doses for whatever reason, you're going to see a little bit of this, okay? And definitely the bitter taste, because that just is with, and in, you know, with this being inhaled. Got to be careful with patient sensitivity to lactose. There's your glaucoma. Why? Because it's an anticholinergic. Okay. Not very many drug interactions because it's inhaled. It's not systemically, you know, in your system. And then obviously assess respiratory status before and after you give it. Watch for those paradoxical bronchospasms because they can happen. And then if those do happen, obviously, don't give any more medication. Call the doctor. Any questions on those sympathomimetics or anticholinergics? Okay, well, I'm hearing crickets. I'm not hearing anyone talk. You can stretch, stand up, do 3 jumping jacks, sit back down. Okay. So these are methylxanthines, or just xanthines. So these are reserved for long-term management of asthma that's unresponsive to the previous medications we talked about. Okay. These guys have a narrow therapeutic window. Remember that? Doesn't take a whole lot to have it toxic. And it, you know, we need enough to get it therapeutic, but not too much. Okay, so we want to monitor labs when we have a narrow therapeutic window on any type of medication. It does have significant interactions with numerous other drugs. So this isn't necessarily something that's going to be our go-to. Okay. It is chemically related to caffeine, which is a stimulant. So that may potentially be a contraindication if you think about it. If it has the same type of chemical relation. And then there is no inhalation option, which is why there are significant interactions, because now you're taking it systemically, because you can't just inhale this one, okay? Or you can get it through your IV or rectally if you want. If you choose to go that route. It's a bronchodilator. It suppresses, it suppresses the airway responsiveness to stimuli that promotes bronchospasms, right? So it's a bronchodilator in a different way with a narrow therapeutic window. This is great with patients with seizure disorders. No, just kidding. Use it in great caution. I totally read that wrong. So you don't want to give it to patients with seizure disorders, heart failure, or cardiac dysrhythmias. Too many to list with the interactions. And then you want to monitor your drug values, your theophylline values. That's how you say it, by the way, theophylline.
And just an FYI, because of these numerous drug interactions, this drug is not utilized. This is not a first line drug. And it's way, way down. And in fact, I hardly ever see it used in adult populations that I deal with. I don't know. Do you see it a lot in the peds, Corby?
No, I don't. But I think it's on here just because it's really the only xanthine that we have. And it is an option. But like I said, it's down there. It's if nothing else is really working. So kind of a last stitch effort.
Yeah, and that would be true. I agree with that. There was one other question I was going to ask. Oh, do you as students understand what that means when we say it's a very narrow therapeutic window? You understand what that means?
You better. I went over it really well.
Okay. Good job.
And if you don't, that's fine. I'll explain it to you again. It's fine.
Coumadin is another one that has a very therapeutic window. That's why they have to test so often. We'll get into that. That's an anticoagulant. There's others, excuse me. That's the reason why they have to do peak and troughs. We'll get into that, into bacterial medications, is because too much is not a good thing and not enough is not therapeutic. So I'll be quiet now.
No, you're fine. What other drugs did we talk about when we talked about that has a narrow therapeutic window? We've already talked about a couple. And I can't think of any. Anyone know? Ah, there you go. Phenytoin. There we go. I knew there was one that we talked about. Okay, so now we're going to talk about leukotriene agonists / modifiers. So there's some that mess with the leukotriene receptors, and then there's some that modify the leukotrienes themselves. So that's what that kind of means. Okay, so leukotrienes are mediators that reduce inflammation. Did I write that right? I think I did. I swear I looked at this slide like 3 times making sure that it was right, and now it's confusing me. Debbie, can you help me out here? I'm having a rough time.
I'm sorry. What I was talking to Renee. Tell me what. I'm being like our students. I'm sure you're all listening with, great things. Say it again. Sorry.
Guys, I swear, I looked at this. The leukotrienes, I have that they're chemical mediators that reduce inflammation, but.
Yeah, that's true because.
Is that right?
Yeah, because leukotriene is a chemical, it's a cell. And so it's released when there's inflammation. That's one of the inflammation cells. And so these modifiers reduce. Everything reverts back to inflammation. If you have too much inflammation, then that's when the body sends all the mucus into the lungs. And then that's when the bronchospasms happen because the lungs trying to get those things out of there. And so a leukotriene modifier like Singular helps stop the leukotriene from being released.
Okay.
Does that make sense?
Yeah. So I think I have this wrong. The leukotrienes themselves can cause inflammation changes. So now we're going to antagonize them with this Singular. So I'll correct that slide too. My bad. You can also look, it's in your book on 524 if you have any question. But so what we're going to do is we're going to stop these leukotrienes from causing any inflammation or mucus production or edema, anything like that, right? So these, you could argue a tiny bit that they're a little anti-inflammatories, but not like NSAIDs. So these are for your breathing, obviously. They're used prophylactically. They're taken orally, so you get the systemic effects. They're ineffective in relieving any type of asthma attack that's currently happening. And interestingly enough, just a side note, these are given for originally for asthma control, right? Breathing control. They are also effective in seasonal allergies in some people. So somebody on Singular doesn't necessarily mean they have asthma. They could just be using it for their seasonal allergies. Okay. So it's a respiratory anti-inflammatory type medication. It's a leukotriene receptor agonist. All these, there's a couple of them. You only need Singular, the Montelukast, however you want to say it. This is the most popular one. There's a couple of them, but they all end in cast. So any drug in cast, you can probably guess it's a leukotriene. Okay, this is a detailed mechanism of action. They block the leukotriene D4 in the lungs. They can cause some headache, dizziness, drowsiness, restlessness, insomnia. Now I know a lot of, and you probably already have seen it, a lot of side effects are contraindicated or contra opposites. You'll get some that say drowsy insomnia, or they're opposites. It just, everybody's different, and this is what has happened when they've taken it, so they have to put it on the list. Contraindications, a severe asthma attack. It's not going to do anything for that. Plus, if they're having a hard time breathing in an asthma attack, you're not going to try to want to shove a tablet down their throat. Bad idea. And then this can affect the liver too, so be careful in hepatic diseases. Drug interactions, aspirin, and then NSAIDs. With this medication, the NSAIDs block the Singular action. So definitely one thing to note. If any of you are taking Singular, NSAIDs will block the action of that drug. So assess lung sounds. Now this is a tablet, so you're not going to be doing it before and after, because this is a long-term preventative type thing. But you do want to monitor for effectiveness, and how would you monitor for effectiveness in these type of preventative medications? You have a patient that's on all these preventative medications, inhalers or tablets alike. How are you going to know? How are you going to monitor their effectiveness? Right, Jessica, asthma is controlled, right? They're not having asthma attacks every day or every week or maybe even every month, right? It's controlled. They've got it under control. They don't have a problem with whatever they're trying to control, okay? They're not having any symptoms, or at least enough to require more intervention. Now, one thing to note, these tablets, singular, does come in a chewable tablet. These chewable tablets are not meant to be swallowed. If you have a chewable tablet, you need to chew it. It affects the absorption. So really important to chew the chewable tablets, especially in this medication.
And this will be part of your education to the patient, because so many times they're like, oh, well, I just swallow pills, so I'm not going to listen. I'm just going to do this. Okay, patients are dumb. Sorry, they can be. And so it's helping them to understand, no, you need to chew this up because this starts the action. This starts helping you. If you swallow it, it inactivates the drug.
Yeah, and they give the chewable tablets a lot to children because, you know, a lot of kids can't swallow tablets. I mean, and they're not big, but they're not totally incredibly small either. So sometimes when you get kids that are growing up on this and they're chewing, and now they can swallow tablets and they're just swallowing it, you need to make sure that either they get on a non-chewable tablet, or they know to keep keep chewing their pill. So making sure they're taking the medication correctly is key, sometimes depending on the medication. So corticosteroids. So we talked about a lot of these previously with the asthma. We're going to cover a couple of them now. Did I say asthma? I meant allergies. Covered some of them with the allergies in the last chapter. We're going to cover a few of them and then go a step further. So inhaled corticosteroids, inhaled ones are used to treat respiratory disorders prophylactically, especially in asthma when other medications don't work. Okay. It's when it's inhaled daily, used as a preventative medication. They suppress the inflammatory response, and it's a direct acting, so it's not going to cause a lot of that major adverse effects when you take them systemically, right? We're talking about steroids. Same thing. You know, the systemic reactions with steroids, you know, is all the Cushing stuff that we went through, right? So this is inhaled. These are inhaled. These are anti-inflammatories that are working direct acting. Okay, so if you're reducing the inflammation and the reaction to the insult on the lungs, you're going to reduce the mucus production. Your edema is going to go down, and it makes you breathe easier, right? These are bullets, by the way. When I say bullets, this is what they are. I knew I had a picture of them. This little top twists off, and it looks very similar to like a tip of an eye drop thing. Anyway, and you can squeeze it out. These are called bullets, in case you didn't know.
Yeah, and that's what I was talking about adding with your SVN, your small volume nebulizer. Except they hold normal saline. So we call it a saline bullet. So that's what I was talking about.
And Debbie, I know you work different corporation than I do, but where I work, the saline bullets are pink.
I have seen that. I think it just depends on which manufacturer they get it from. Yeah, it depends. But yeah, and that helps us to differentiate between. But yeah, some of them are pink, some of them are not. Depends on where we get them from.
Yeah, and I know you guys are doing clinicals like back and forth between hospitals and stuff, and some of you might, you know, become like a travel nurse or something, and you're going back and forth between like clinics or hospitals. Don't depend on the color of things, please. Like, you need to be reading the label. You need to be reading what it is to make sure that you've got what you want. Okay, just a side note, don't depend on the color. All right, or the size. Okay, so when you start these corticosteroids, you're going to see some improvement within the first 1 to 2 weeks. I mean, they're steroids, they're pretty good stuff. But to get the maximum benefit, as with most preventative medications, it takes a little bit of time, and it'll take 4 to 8 weeks before an inhaled corticosteroid is going to be working the best. Okay. A lot of times, a short-acting beta agonist is going to be prescribed with, not just with corticosteroids, but with some of the other preventative ones too. You're going to have your controller, and then you're going to have your rescue inhaler. So a lot of people have two different types of medication. One to control that they're going to be taking daily or sometimes twice a day to, fend off those asthma attacks. And then they're going to have their rescue ones for when they do have an asthma attack, they have something that will stop it as it's happening. Okay. And then let's see, we've got our beclomethasone, or fluticasone, Flovent, fluticasone, salmeterol, that's Advair. So we have those. Okay. Now, Kylie, I think you brought this up earlier in the day. So, in moderate to severe asthma attacks, severe exacerbations, oral or IV administration of steroids is going to be needed. Okay. This is, I see this a lot in kids. I'm sure it happens a lot in adults too. They'll come in with a moderate to severe asthma attack. This isn't, when you have a severe asthma attack, it's not something where you go and you have a 2-hour ER stay and then you're like, oh yeah, I got that medication, I can breathe fine, I'm done. Sometimes this is like over a course of a couple days, and you're just slowly getting better, and you're continually getting the albuterol every 2 hours, stuff like that. So this is like over days. So to help with that, you get IV or oral steroids, which work really well. So as we talked about, if they're prolonged administration, which I think we decided was about 2 weeks, they need to be tapered off. You have to treat them just like a regular normal steroid, right? Take them with food. They can irritate the stomach. These are dexamethasone, methylprednisolone, prednisolone. There's methylprednisolone. There's a whole bunch of all different kinds. These are the most common. They're given IV or PO. One thing to watch out for, though, if you're taking them, we talked about with the prednisone with the mood changes, you can get what's called roid rage. And for kids, it only takes a couple of doses to start seeing effects of this roid rage. And it's impressive. Debbie, did you have something to add?
Yeah, I'd love to add it. So when a person comes into the ER and they're they have an asthma attack, obviously, what would you expect to see? We're going to hit them immediately. And in the comments, what do you think we're going to use? What's an immediate or a rescue medication we've been talking about today? And then I'm going to go on from there. So type it in. Need to see you. I haven't seen anything. Okay, yeah. So we're going to give them a nebulizer treatment, trying to open up that with albuterol, the DuoNeb. Then we're going to hit them with these corticosteroids, usually either PO or IV, depending on how severe it is. Now you need to know there's a difference. Most of the time we will use we use like a dexamethasone or a methylprednisolone. Those are not your prototype medications, but in terms of in this class, but they are medications you will see every day in clinics and every day as a nurse. The difference is prednisone and methylprednisolone are intermediate, meaning they're 4 to 5 times more potent than other steroids. Dexamethasone is long-acting. So methylprednisolone is intermediate, which is what we would then do. Dexamethasone is long-acting, and it's about 25 times greater than the short-acting products, okay? So we hit them with that albuterol. Then we hit them with the dexamethasone or the methylprednisolone. Then we send them home with a prescription of prednisolone or prednisone, which then is a tapered dose, just like what Corby is saying. So we attack it, and then we help to try and give some long-term relief, and then we do a course to get it reduced, that inflammation reducing. One of the things with prednisolone or prednisone, you do have that road rage. You will also be so hungry, like you can't get enough. It is a great drug, and it's a horrible drug. And some people have to be on it for a long time. It's like, Megan said, she felt like she was a crazy person. So we don't go over prednisone. I'm not going to, ask you to do that, other than it doesn't hurt to have kind of like add that to your list of medications to kind of look up the side effects, because your patients are going to go nuts with it. And it's a very common medication used in hospital and at home. That's what I have to say.
Great. Yeah. So, yeah, I know we talked about prednisone for a hot minute when we talked about immunosuppressants. We're going to talk about it again when we talk about oh, man, why can't I think? When we talk about our hormones and stuff like that. So prednisone will come up a few times, but do know the side effects of steroids with the thin skin, the moon face, the stretch marks, the mood changes. Like I said, with this roid rage, you see it a lot in kids. It only takes a dose or two, and they are like off their rocker and angry. And the parents will be like, I know, this is not him. And you're like, I know. It's the steroids. It's fine. And it'll taper off as the med tapers off. So anyway, just know that this is given, it's not going to act nearly as quick as like the albuterol. Like Debbie said, we're going to hit them with the albuterol, maybe the ipratropium, get all that stuff, and then give this. We usually don't see real good effects from oral or IV steroids till about 10 to maybe even 18 hours after. But like I said, this isn't a severe asthma attack. You're going to be treating it for a few days. So, but it's good to get these steroids on board because they're really good. They're really strong. And it's interesting because some people, you can see a switch turning them and you're like, the steroids are working. It's really, really interesting.
And so this is where you need to understand how corticosteroids work. Have you ever seen dexamethasone, also known as Decadron, especially some of you guys that work in peds, used in other disease pathologies? Or if you have kids, croup. It's exactly right. But again, it's the same mechanism of action. It is reducing inflammation. You're still going to have these same side effects, okay? So you still have to know them. But what does the drug do? It reduces inflammation. Okay, well, what does that mean for the nurse? And what education should you be giving to either the patient or the parents? That's where the blue boxes come in your textbook. That's where you live. Does that make sense? This is where you all shake your head and type.
She's getting on you guys to reply. I usually just have crickets every single lecture. It's fine. I know deep down inside you guys love me. Okay, so one thing to note that's really important with these corticosteroids, the inhaled ones, is that they can cause what's called a candid albicans. Okay, it's like a What is it? Is it a fungal infection?
It's
Is-
yeast. It's yeast.
Oh, yeast. That's where I was going. Yes. Okay. Candida. That's right. So it's like a yeast infection. You can see it here. It's like white, a white coating on there. And so that's just from the medication. You inhale it. It's in the back of the mouth, on the tongue, can be on the sides of the mouth. And that's from the medication just kind of sitting there. And what do steroids do? Like what's one of the things long-term steroids can do? Right, Amy, immunosuppress. So if you have a large concentration of that medicine sitting in the back of your mouth, it's gonna immunosuppress the back of your mouth. And so you'll be more susceptible to this stuff, and it's yeast. So
Well, and think about it. We as people are more bacterial than we are human, and so we have bacteria in our mouth, and so the the prednisone is going to reduce the good bacteria, and the bad bacteria, which is the yeast, is going to grow.
Yep. So a good remedy for this, because nobody wants this, right? So you can use a spacer, which helps wash in the inhaler mouthpieces and rinse out your mouth after each use. It's good practice to rinse and spit. You're not necessarily going to want to swallow this stuff. So you're going to rinse your mouth and spit it out. Okay. Another thing to note, and it's asterisk. If you see anything asterisk, you might want to take tiny bit of extra attention to that, is that children on corticosteroids are at risk for growth suppression. Okay. So you might see some kids on some of these, and they just need to be monitored. The Qvard, the Flovent, Advair, they're very widely used. And so if kids are on there, they just want to monitor, make sure they're still meeting, they still have a good growth rate and they're not getting any type of suppression on there. So, okay, mast cell stabilizers. There's just one med in here, which is great, right? Is the cromolyn. So we watched that video previously, right, of the mast cells, and they come with the receptors, and then the pollen or whatever comes in and hooks onto there, and then the mast cells secrete all of these, like the histamines and the prostaglandins, and that's what causes all of our inflammation, okay? This is a mast cell stabilizer. So what it does is it just does that. It stabilizes those mast cells and says, whoa, calm down. You don't need to release all this crap, right? Just take a breath. You're fine. Don't go crazy and start, releasing all of this histamine and stuff like that. So cromolyn goes in there, calms the mast cell down. The mast cell doesn't release the histamine. Then we don't get that inflammatory response, okay? It's a safe alternative to the steroids. It can be, it's an inhaled anti-inflammatory with the mast cells. It's only moderately effective though. So it's not widely used. There are better medications out there. So not only moderately effective. You're not going to see this used in everybody. Okay. You can get the postnasal drip, irritation of the nose, throat, and cough, rebound bronchospasms. It's not going to help with any acute asthma attack. It's not a rescue anything. And then it doesn't have very many drug interactions because we're going to inhale it. It's going to have that direct acting, stay right in our lungs. Okay. So let's see. We're going to drink water before and after use with this one. Must be tapered. If you're going to be taking this, you want to come off of it. This is when you must be tapered, or you can have rebound asthmatic attacks. You're not necessarily going to, it's not widely used. Okay, so we're going to talk about mucolytics here. Mucolytics. Similar to expectorants, not the same thing. And they're not interchangeable either. But they kind of do the same thing. Kind of. Mucolytics loosen the thick secretions in the bronchioles, okay? But instead of, you can think of expectorants as taking the water from your body and mixing it with the mucus to thin it out, right? That's why I want to drink lots of water. What mucolytics do is they break down the chemical structure of the mucus. So it's kind of like you have a ball of like detergent bubbles, right? And that's all your mucus. And these mucolytics are going through and just popping all those bubbles and just breaking it down. So the mucus is just kind of loosens up, and it's not nearly as thick and clumped up. It's not an expectorant, and it's not used as an expectorant. These are used for mostly for cystic fibrosis patients. Okay. And it's acetylcysteine, or called mucomist, mucolytic, mucomist, acetylcysteine. It's delivered inhaled route. It's not available over the counter. This is something where, like, a patient with cystic fibrosis or similar disease will go into the ER and have problems breathing. They'll give mucomist to help break up all that mucus. Okay. It's not used for colds, coughs, flus, nothing like this. This is more of a emergent type drug because it's not over the counter. It talked about it. It liquefies and loosens the mucus secretions. It breaks them down chemically, so they become thinner. Now, acetylcysteine, if that sounds familiar to you, it should, because we also give that IV for acetaminophen overdoses. Okay. I hope, don't confuse mucolytics with expectorants. They're not the same thing. They don't treat the same thing, even though you have the same outcome. Okay. I don't want that to confuse you. So these, for the mucomist, for the lungs and the mucus in the lungs, it's given inhalation route. For acetaminophen, it's given IV route. And how that works is the acetylcysteine systemically will attach to the acetaminophen, and so then it can be, oh my heck, I don't know why I always do this at the end of my stuff. I always am a loss for words, but metabolized. So then it can deactivate the acetaminophen and metabolize it. Okay. All right. Any questions on mucolytics? These are like for serious, like I said, cystic fibrosis, other similar lung diseases like that. Not just for a simple asthma attack or a cold or the flu or anything like that. Okay, those you're going to use the expectorants for. Okay, so one thing to absolutely, and I know I've mentioned it a few times, every individual is different. So the drugs, the dosing, the usage depends on the individual. You're going to see a lot of combinations between inhalers and tablets like the Singular, a lot of, different combinations. And it depends on their age, disease severity, medical history, the patient, and the physician. Okay. So there's really no wrong or right way to combine all these medications to help with either cold or flu or allergy symptoms or asthma and COPD and stuff like that. So combinations all over the place, endless combinations of treatments. Okay. We don't have much time left, so now we're going to go through real quick about drug delivery. So I've talked about all these inhalants. Now you guys, part of your role as a nurse is to make sure that these patients are using their medications and the methods correctly. So let's go through those real quick. Okay, talked about inhalants and aerosols. really small droplets of the medication or the liquid to be able to get down into the lungs. Oh, hold on. Here is for your enjoyment. I hope you guys got a kick out of that. That's one of my most favorite things. I love how he's like, "Are you using it right?" And she's like, "Do I look like an idiot?" I mean, it might be, to us, it might be like, this is so simple. Like, it spells it out for you how to use it. But they, they just don't. They don't see it. They weren't taught right. So here is a metered dose inhaler. Okay. It's the most common way to deliver a lot of these respiratory medications. They have a propellant to deliver the metered dose. It's under pressure. You just, push it down. It'll spray it out, okay, with each breath. Here's how you position it. You don't spray it on you don't spray it like perfume. You have to inhale it. Wrong one. Hold on. Hold on.
They fix it.
Wrong one. You can watch that again. It's freaking hilarious.
How to use reviewing this video from the American.
You like that? I loved how she turned and she was like, "I'm so happy." So that was with a spacer, which I apologize. Which is right here. Okay. So that's how to do a metered dose inhaler with a spacer. There's a couple different spacers. These ones have the mouthpiece, just like the metered dose inhaler. Okay. You put it on one end, just like she said. This one right here for more smaller kids that can't really coordinate the breathing with the mouthpiece and the inhaler. And so they have a mask on them. And so you put the mask, it covers their whole face. So if they're breathing through their nose or their mouth, it doesn't matter. They can still get the medication. Goes over their whole mouth. And then you can coordinate the sprays with their breathing. Okay. So that's how to use that with a little child. Here's how to do like a metered dose without a spacer. All right, so that was not incredibly entertaining, but definitely step by step. So I know it was like so computerized. So really important to to inhale as you're spraying it. So you're not spraying it in your mouth and then inhaling, right? It's just gonna get stuck in your. It's just gonna be in your mouth, and if you swallow it, it's not gonna get in your lungs, right? Because we want the direct acting. So breathe in and spray at the same time. Which, can you understand with kids, a spacer is a good idea, because sometimes they can't coordinate the whole like breathing in as they're spraying and stuff like that. So these spacers are really good, especially for kids who can't coordinate that. Okay, we already kind of watched, this is another video on how to do a spacer, but the previous one was, so we won't watch that one, but you can. Okay, so now we have nebulizers, which are small machines that vaporize the liquid drug into a fine mist. So this is even finer than what you're going to get with a metered dose inhaler. So a metered dose inhaler, you're going to get like the small drops of liquid that's small enough to breathe in. With a nebulizer, it's gonna look, it's like steam. It's gonna look like steam or like a smoke type thing, and so it vaporizes the liquid to the fine mist that can be inhaled. So here you have, this is kind of what one of those machines can look like. What Debbie was saying, like in the hospital, you can have these masks with the little chamber on the bottom, these chambers right here. The oxygen that it's hooked to on the wall, if you turn it up high enough with these chambers, it does the vaporizing for you. Now, people don't have oxygen, readily available coming out of their wall at home. So they have these machines that do it. And so you can use it with a mask. It's got these mouthpieces that you can just stick in your mouth, and you can breathe in, and then it'll blow out, and you'll see the steam type stuff come out this end. So those are really handy, especially with kids with asthma stuff, right? Okay, now we have a dry powder inhaler. So this isn't this one specifically is Advair. It looks like a little hamburger. Pretty interesting. So should we learn how to do that? That's what they look like when you're actually, she's like giving herself a dose right there. So they do look like little hamburger. So let's learn how to use them. Okay, I didn't explain the whole dry powder thing. So the metered dose inhalers, and the nebulizers, they're all liquid. You can see they have like little canisters in them, and they're liquid in there. These dry powdered ones, how they work is they have this really, really fine powder that's the medicine, and they're in little capsules in the machine. Okay, so they're in these little capsules now in these machines. When you open it up and when you're pushing that little knob down, sorry. So you're pushing that little knob down. What that is doing is piercing one of those capsules. Okay. So unlike in metered dose inhaler, when you push the canister down, it'll spray out. With these ones, they don't. They pierce the capsule and then it just sits there. So then you have to inhale really strong and deep to be able to suck all that powder out. Does that make sense? So that's why, like, she didn't push anything. Let's see if I can go back to that video real fast.
Powder, you have to breathe in fast and deep.
So see how she's like holding it? She doesn't push anything.
And deep to get the medicine into the lungs. Play print from meter dose
Let's
inhalers.
see.
Unlike other inhalers, which deliver a puff of medicine, these inhalers hold the medicine as a dry powder.
Yeah.
Since the medicine sits inside as a powder, you have to breathe in
Go right
fast
here.
and deep.
So see, she opens it, and then
and
that
breathe
right
out.
there is
Do
piercing
not
that
breathe
capsule.
into the inhaler.
So then
Close
she
your
can
mouth
hold it up to her
lightly around the
mouth,
mouthpiece while holding the device flat.
and then she breathes in,
Breathe
and that's
fast
how
deep through the
you
mouth.
get the medication.
Hold it like a hamburger.
Sorry, I know it echoes when I have it going. So anyway, so that's how the powdered meter doses work. They're in like a little capsule. You have to pierce them. You don't push anything. It doesn't like shoot into your mouth. You have to breathe it in and suck it all out. Okay, does that make sense? Does that help? Okay. So I know these are really short videos. You're welcome. Like I said, I should have all the links under the note section of the PowerPoint, but there are like 1,000,002 different videos you can watch on YouTube if you're wanting to, but you will eventually potentially teach a patient how to use one of these inhalers. Okay. So that's all the new stuff we have. That's all the information I've got from chapter 35 and 36. So now we're on the review. So name the 3 types of devices used to deliver drugs by inhalation route, and what are the differences among them? So we've got the meter dose inhaler, we've got the nebulizer, we've got the dry dose inhaler, right? So 2 of them use liquid. The dry powder uses powder, right? The dry powder you have to suck in. The other ones, the nebulizer is just like steam. It's like if you hold your head over like boiling water. It's not like heated by any means, like when you're breathing in steam. So it just continually vaporizes that water and mists it. And then you just sit there and you're just breathing it in and out, in and out, in and out. And that's how it is. Where with a metered dose inhaler, you're taking a big breath as you're spraying and you're holding your breath, right? With the nebulizer, it's just continually misting this air or misting this fluid into your face, and you just breathe it in and breathe it out. There's no holding your breath with that or anything. You like my face, my hands in my face? Okay, so distinguish the classes of drugs that prevent asthma attacks from those that can terminate an asthma attack. Okay, and then name at least 1 drug in each class. So I want you guys to pick a class and name a drug. We'll just throw them on the chat. Anyone got one? Okay, Amy, what's There you go, albuterol. Fantastic. The short-acting beta agonist. Albuterol. Perfect. Somebody else got another one? A different class and another medication to go under that? Did nobody take notes? Okay, perfect. Stephanie, corticosteroid. We got the dexamethasone, prednisone. And those are for terminating an attack, right? Both of those, the albuterol and the corticosteroid examples that Stephanie gave. To terminate, right? Okay, perfect. McKenna, let's go trying with the Montelukast, the singular. And that one's going to be a preventative, right? Perfect. Xanthines, theophylline. Okay, so you guys get the picture. You guys get it. I don't want to keep you too long. We're almost at the end. Okay, so we've got a nebulizer treatment of metapaterenol. This is similar to albuterol, right? It's a short-acting beta antagonist. The most important for the nurse to assess the patient for the development of which side effect or adverse effect. Now, if you look at them, they're all very important to watch out for. What's the most important? Anyone other than Taylor have a guess? Taylor's totally right. Tremors. Okay, so let's go through this. So metapaterenol is a short-acting beta antagonist, right? It's a SABA. So it's a beta. I said antagonist, I meant agonist. So it's going to stimulate the sympathetic nervous system. So what types of things we're going to get? Excitability, we're going to get the bronchodilation, the tachycardia, hypertension, hyperglycemia, right? So here we've got that's bradycardia, hypotension, and hypoglycemia. So tremors is right, because these ones are not going to be what you're looking for when giving a SABA. These are opposite. Okay. All right. Patient with COPD asks the nurse what the albuterol he is taking does. The nurse should inform the patient that albuterol is used to mobilize respiratory secretions, decrease cough, increase work of breathing, dilate the airways. Perfect. You guys got it. Dilate the airways.
Yay, you were listening.
The nurse is preparing a class 4 patients with asthma. The nurse will inform the patients that leukotriene modifiers are used in the treatment of asthma to what? What do leukotriene modifiers do? Or antagonists, same thing. Or they do the same thing. Assist in opening narrowed airways, suppress the release of histamine and decrease inflammation, loosen mucus from the airways, prevent serious complications from bacterial infections. Perfect, you guys got it. Release or suppress the release of histamine and decrease inflammation, right? That's a controller drug. One we're going to use to prevent.
Back to what is the purpose of the leukotriene, okay? And so if you know that that's what's happening, then you're going to understand that it's going to suppress the histamine, decrease inflammation. So part of this goes back to pathophysiology and to anatomy and physiology. So if you had biomed a few years ago, or you had physiology a few years ago, you're going to have to bone up on these, on these, what am I looking for? Disease pathologies. And that's part of the learning objectives. If you look at number 1, it says analyze the pathophysiology of respiratory disorders. upper respiratory infections, and allergic rhinitis. That is what we are teaching, okay? And the test is developed from these learning objectives. So again, making that connection between the objectives and then the prototype medications that represent that. And then what is a nurse, as a nurse, are you going to do or teach or be aware of to keep your patients safe? Does that make sense?
Safety is key, whether it's dealing with contraindications, watching for side effects, teaching. Like, ultimately, if I could sum up pharmacology in 2 words, it would be patient safety. Because that's really, like, we're trying to treat these things, but ultimately we want to keep them safe, which means keep them breathing or keep their blood pressure down, or, so patient safety, using all of those things and applying it to the safety of the patient.
Right. And pharmacology is different than other courses that you've had in terms of, we don't spoon feed you. This is part of that transition, and you taking that initiative and helping to make those connections. If you have a hard time making the connections, that's what we're here for. But these are going to be harder questions, because it's not just regurgitating information, it's applying it. It's that you understand the medication and now you're able to apply it in a patient's situation. I'll be quiet now.
You're great. Okay, last question, guys. Patient using glucocorticoid inhaler. Excuse me. Patient asks the nurse why he has to rinse his mouth out. So what are you going to tell him as a nurse? Why? Because the packaging says. Right? Oh, that's not an option. Because the doctor told me to. Oh wait, that's not an option either. Because my nurse supervisor told me to tell you. Oh yeah, that's not an option either. Yes, to decrease risk of infection. Correct. Okay.
You guys have rocked it.
Okay. You guys, if you have any questions or I need to clear up anything, or maybe you start studying and you're like, whoa, this is now confusing when I didn't think I was confused before, please reach out to either me or Debbie. We can clear things up. We can fix typos or things that I've messed up. We can help maybe explain it to you in a different way. Like, whatever you guys need, just let us know. Yes. Oh, yes. Woo! Let me tell you about this learning activity. Okay. So I hope it worked. I threw it together. It is a virtual escape room. Are you guys ready for this? This is going to be amazing. So what you have to do is I'm going to post the link on. And
it took me 3 tries on level 1. I don't escape well.
It's fine. It's fine. So you have to answer. I think there's about 3 questions per each lock or each room, right? So you have to answer the questions, and then you have to put the order of answer that you put in. Like, if there's one that's like, there's a couple of true false questions. So if the first question's true, the second question's false, the third question's false, then in the bottom you would put TFF. Does that make sense? And then you hit submit, and then if you pass and put the right answers, then it'll take you to the next lock, and you have to unlock that one. And you go through and you answer the questions, and then you should be able to get through all the locks. It's like a virtual escape room.
And
I'm rather excited about it.
Instead of just guessing or re-guessing, take your book, look it up, find out why you didn't get it right. That helps you to learn.
You're going to retain it a lot better if you get it wrong and then figure out what's right. You're going to remember that. Okay, so if anybody has a problem with the escape room, I've had a couple people try it out and it seems to work, but there's, you never know. There's always those snags. if you have any questions with it, send me a text or a message, probably a text because it's due tonight. And so I can help remedy the problem so you can get through it. Okay. Alina, so you're just clicking on a link. It tells me when, it tells me who does it. So you don't have to submit anything. You just have to go through all the locks and get to the end. You'll know when you get to the end. And you just go through all of them, answer all the questions. It shouldn't take you too long. I think I've mentioned everything, all the questions that I put in there. And so it'll tell me when you've completed. It'll populate your name on there. It's through Google Forms. So you don't have to submit anything. But let me know if you have any problems accessing it or have any problems getting past the lock or something like that, okay?
And then just as a side note, I'm probably going to put something on a SurveyMonkey, and I'll send it through Canvas, your Canvas email. It's an anonymous thing. I just want to try and gather some data. I'm kind of coming new in this, and I just kind of want to know where you guys are at. And so it's things like, you know, are you in a study group, or how many hours a week do you study pharmacology? Things like that. It's very easy. It's very quick. And then come into my office and get a candy bar for your reward when you come back into class next week, so that I don't eat all of these dumb candy bars. But anyway, take a look at that. It'll be in your Canvas email the next couple days or so. It'll take maybe 2 minutes to answer, and but it'll really help me. Okay, so would you do that for me, pretty please?
Okay, guys, it's published in there. It's published in there. It's ready. Like I said, let me know if you have any problems. Okay. Thanks for being here and listening to us. And I'll fix those on my PowerPoint and republish those so you have those corrections. And let me know if you have any questions, and we'll get the grades to the exam